Okay, good evening and good morning to everybody. And this was the idea which came across from Raghunath and Ginil when they caught me in a conference in Lucknow, last Uro-Oncology conference which we had, where Chris was there to make a society for genitourinary oncologists who are focusing on urological cancer. We should include all the doctors from all the subspecialties so that we can talk, update ourselves, update our juniors, and talk about science, which is actually progressing in cancer like anything. Before that, if I remember, I never knew about GU ESCO society, which Chris introduced me way back in many years back, because me and Chris are there for know each other since 2005. And he told me that this is the conference for which you should come. AUA gets diluted. In AUA, you will not see that thing which you see in GUSCO. And to my surprise, that was the conference when I attended first time. I really liked, and I was going every year, except this year I had not gone. This is the society which we are trying to make already. It's under process of registration. And we are bringing all the doctors who take care of uro-oncology patients in medical oncology, radiation oncology, and urologist. With that, we are also inviting the people who are from allied branches like radiology, pathology, and molecular oncology. And we hope that we can start fellowship and then progress to the training program, and then hopefully the journal also later on. As I had discussion with Dr. Hemal, he suggested that later on you can think of a starting journal. But that's the later part. But at least it's a humble start to having this is first webinar. We thought we will do a great conference in April. And but then because of the COVID, we met Dr. Kulkarni, who is first president for this society, and Vedang in TMH last February when we had the conference, and then we decided that we can't have a conference because of the COVID, so we cancelled it. And later on the things as they shaped up, so we thought let us have at least webinar. And this is the first webinar of this society. The real aim and objects will be, once we have the conference in person, we'll be discussing at that time. We'll be showing you everything that time, and the council members and all. As on today, Dr. Kulkarni is president, Raghunath is secretary, and Ginil is our treasurer. And to make sure that the society runs in a long way with honest purpose of science, we will have a central office. That's what we think, and which will be organized the conference and all the academic activities. With that, I would like to have, because I had discussed about the society to Dr. Ganesh, Dr. Nitin, and Dr. N.P. Gupta also. So I would like to have some words from Dr. Ganesh first, then Dr. Mahesh Desai and Dr. Nitin can tell us. I don't see Dr. Gupta here, though I have invited him personally also. Maybe he will join later on. So Dr. Ganesh, please.
Good evening to everybody, and well done, Sudhir, for kickstarting something of this nature, which probably is going to make uro-oncology climb the ladders even more. At this point, I would like to say that what has been renal transplants loss has been uro-oncology's gain. Sudhir was slated to become a renal transplant surgeon many years ago when he trained and left Vellore. But then he decided that he would do uro-oncology. And I use him as an ideal example of somebody who branched off into subspecialty very early. I know the trials and tribulations that he faced, but see where he has gone. And I know that people like Ginil and Raghu, they have actually discussed many things with me, and I've said just stay focused on it. These things don't happen overnight, and it's a long grind, but it allows you to have your staying power intact, and that's what you have shown and what your colleagues in the society have shown. Of course, you've got to give credit to Dr. Jagdish Kulkarni because he has been one of the pioneers of uro-oncology, and in Mumbai, he and at TMH, and along with Srini in Hinduja Hospital and Dr. Kamath at TMH. They were the people in India who actually spearheaded uro-oncology in a big way. And credit to all of them at this point, and credit to Sudhir for having cemented all these people together and getting together on a one platform. And let's hope that his dreams and the dreams and aspirations of many uro-oncologists in this country would take fruition. All the very best to the society and all the very best to you and the office bearers. Thank you very much.
Thank you, sir. Dr. Mahesh Desai, please. Sir, you are mute. Please unmute yourself.
Can you hear me now?
Yes, sir. Yes.
Okay. This is an excellent idea. I think this is the need of the hour because the technology has progressed so much, and now it is not and then option of the treatment has widened. It's a teamwork, and as you see today's the sub topics which we are discussing are the a very finer topics, and for that you need to have a discussion and to have knowledge and to have the teamwork. I think it's an excellent idea, and I congratulate you, Jagdish Kulkarni, Raghu, and Hinil to start it, and we have all the full support to us. Thank you.
Thank you, sir. Thank you. Dr. Nitin, please. Dr. Gupta, I don't see him. Maybe we'll talk here. We can ask him later on.
I would start
Yes,
first congratulating you and Raghu and Renal, everybody who was involved in forming this society. Any society, when it takes birth, is a natural evolution of the development of science which is happening. And oncology and now uro-oncology, and in future you'll also have further branches of uro-oncology. I'm very happy that you are already making it inclusive. It's very, very important that we should not just concentrate on surgical aspect, but involve basic sciences, radiation oncologists. And I also suggest you need to involve nursing, because the uro-oncology nursing also is a very, very special part of it. And of course, with that, the research and the data collection from India would get a proper shape so that tomorrow we will exactly know what is happening in our country. So it's a great beginning. And I think we must pay our respects, as Dr. Ganesh said, to Dr. Kamath, Dr. Jagdish Kulkarni, Dr. Srinivas, who were the pioneers who did only uro-oncology in their days. And because of their efforts, then now we are able to see this. And Sudhir, as Dr. Ganesh has said, I think words are not enough for what you have achieved. And I'm very, very confident that you will go, and under your leadership and with your guidance, all of this society would prosper and would do a great job. So my sincere good wishes for the best of the society, which will ultimately better the patient's care and, of course, the research in the field of uro-oncology, which is sadly lacking from our country. Thank you very much.
Thank you, sir. And since Dr. Kulkarni has joined, I will just say that Dr. I came to know his name when I was being trained in CMC Vellore. He came for a conference when Renal has come. And that time, Dr. Vishambarnath was there. He said, Dr. Kulkarni is coming and he's the only one who is doing radical prostatectomy in India. So I really got fascinated. And when I came to North, so I got chance to go to Rajiv Gandhi, where he, at that same year, he was organizing a USI conference, National Congress. I was like kid at that time, but he said to one of our radiation oncologists, well-known radiation oncologist, Dr. Huku, that tell him to join the conference because he is, I see someone who is actually there in the North also. So with that, I'd like to say Dr. Jagdish, he can say a few words and then we invite Raghavan to carry on the forward program forward. Sir. Sir, unmute yourself.
Yes.
Yeah.
Are you audible now? Can I hear?
Yes,
Can
sir.
you hear
Yes,
me?
sir. Yes,
yeah,
sir.
Okay. Well, thank you, Dr. Mahesh Desai, Dr. Ganesh, Dr. Nitin Kekre, and of course to my younger colleague, Dr. Raval, whose efforts have really fruition to this level now. What I would do is I would now request you to get going with the program first, and maybe in the end I will put my vision or whatever you can call it. Thank you very much.
Yeah. So Raghavan, please take over now to conduct first session.
Sir, dear sir, thank you so much, and esteemed colleagues and respected faculties. It's just amazing to see the absolute stalwarts of uro-oncology in this forum. It will be a pleasure and treat for the audience who are going to see this program as well. The first session is about to start. It's on the locally advanced cancer. The chairpersons are Professor Ganesh Gopalakrishnan, Professor Mahesh Desai, Professor N.P. Gupta, and Dr. Anand Kumar. I do not know whether I can introduce any of them. I'm not even sure whether I'm qualified to introduce any of them. I just invite all of them. They are all people who are all my teachers. I request all the chairperson to step in and take forward the meeting and invite the speakers to take forward the meeting. Ganesh sir? Ganesh sir is muted.
I think it's going to be Dr. Nazir who's the first speaker.
Dr. Chris Wood, Dr.
Chris
Amnesh
Wood.
and Kuchikar are the three speakers, sir.
Okay, you could go ahead because you have the list in front of you. I don't have the list in front of me. I got to open my mail. So
in that case, I will request.
Just go ahead.
Sir, I request and invite Dr. Christopher Wood, Professor Christopher Wood, to give his lecture on management of locally advanced RCC, especially in the role of neoadjuvant therapy. I saw Dr. Chris Wood a few minutes ago. Sir has started. Thank you.
Okay, thanks very much. And again, congratulations to you all on the formation of this society. I'm honored to be in the first meeting associated with it. Wish we could do it in person, but this is the next best forum for that. Since other people are going to be talking about IBC thrombus and nodal disease, I figured I would focus my attentions on the role of neoadjuvant therapy in the management of locally advanced renal cell carcinoma. Okay, hold on. There we go. So this is the outline of my talk. Basically, I'd like to first define what we're talking about when we talk about neoadjuvant therapy as opposed to pre-surgical therapy, some of the initial reports on the effectiveness of neoadjuvant therapy, and then the different goals that might be accomplished with the use of neoadjuvant therapy for locally advanced disease. Talk a little bit about the safety of this approach, and then talk about next steps and take-home messages, and also present a case of mine that was treated with neoadjuvant therapy with good results. So with regards to definitions, neoadjuvant therapy primarily refers to treatment in the M0 setting in the absence of metastatic disease, where a patient is treated with a given drug and then undergoes nephrectomy, and in the absence of metastatic disease is observed after surgery. And this is compared to pseudo-neoadjuvant therapy, or what we refer to commonly as pre-surgical therapy, where in the setting of metastatic disease, the patient is treated with a drug, undergoes cytoreductive nephrectomy, and then is continued on some drug, either the same drug or a different drug after surgery. And why would we want to use pre-surgical or neoadjuvant therapy? We might use it to decrease tumor size and make for an easier resection of the tumor. Perhaps allow nephron sparing by changing a radical nephrectomy to a partial nephrectomy. We might make the unresectable resectable. In the setting of an IVC tumor thrombus, we might decrease the level and or size of the IVC tumor thrombus and perhaps improve its resectability and ease of resection. And in the setting of metastatic disease, pre-surgical therapy has often been touted to be used as a litmus test to better select patients for cytoreductive nephrectomy. One of the first reports of pre-surgical therapy came out of the Netherlands, where they had 17 patients who were treated with sunitinib with their primary tumor in place. They had 4 PRs, 12 stable disease, and 1 patient did have progressive disease, but they noted a median tumor reduction size of 31%. So can we make a large tumor smaller and ease its resection? There are a whole host of different studies out there, some in the setting of metastatic disease, others in the setting of M0 disease, such as ours with axitinib. And you can see a variety of different activity with regards to median diameter tumor reduction. People always ask me, which targeted therapy do I think is the most effective in this setting? You can see with axitinib, there was a 28.3% tumor reduction. You see very similar activities with pazopanib in the M0 setting as well. But all these targeted therapies appear to have activity in that setting. So this is a summary of the effectiveness of reducing tumor size. You can see that bevacizumab really has no activity in this setting and really does not belong in the neoadjuvant therapy setting if the primary goal is tumor size reduction. Sorafenib has really minimal activity, whereas sunitinib, axitinib, and pazopanib appear to have significant activity in this setting allowing for tumor reduction prior to surgery. Can we make the unresectable resectable? Well, again, there are a variety of different studies out there looking at this factor. The biggest problem is that what might be resectable to me might not be resectable to you, so it's a very subjective study endpoint. But Thomas et al. Published on 19 patients, 15 of whom had metastatic disease. They were unresectable for a variety of reasons, including 12 patients who were technically unresectable and 7 who had a large metastatic burden. But of the patients treated with sunitinib, 4 patients ultimately were able to undergo nephrectomy. Axel Bex also reported on the activity of sunitinib in this setting. He had 10 patients with metastatic disease. 3 patients were able to undergo radical nephrectomy after treatment. And then there was a prospective study led by Brian Renal, where he looked at 30 patients, 19 of whom had metastatic disease, and of them, 13 met the primary endpoint. What about changing a radical nephrectomy to a partial nephrectomy? Again, a very subjective endpoint, because what might be a partial nephrectomy to me may not be a partial nephrectomy to you. But taking that in hand, Hellenthal reported on 20 patients, 4 of whom had metastatic disease, and of those treated, 8 patients were able to undergo a partial nephrectomy. Silberstein reported on 12 patients, all of whom underwent partial nephrectomy after treatment with 2 cycles of sunitinib. Jose Karam here at MD Anderson reported on 24 patients who were treated with axitinib, 5 of whom ultimately were able to undergo partial nephrectomy. And then Brian Renal again reported on the activity of pazopanib in this setting with 25 patients. 6 of 13 patients treated were able to undergo partial nephrectomy. What about downstaging an IVC tumor thrombus? This is becoming much more common in the community, unfortunately, where patients with IVC tumor thrombi are started on TKIs and then sent to major centers for resection. We reported on a multi-center study looking at 25 patients who were treated predominantly with sunitinib, and only 3 patients actually demonstrated any significant decrease in their tumor thrombus. 1 went from a level 4 to a level 3. 1 went from a level 3 to a level 2, and 1 went from a level 2 to no thrombus. But you can see it's not a very reliable thing that you can predict in treating patients with IVC tumor thrombi. There was another retrospective study looking at 14 patients, all of whom had clear cell. Only 1 patient demonstrated any significant decrease in the level of their tumor thrombus, going from a level 2 to a level 1. Another retrospective study looked at 22 patients, 18 of whom had clear cell, 18 of whom received sunitinib, and there were only 2 partial responses by RECIST criteria. There is a prospective study that I believe is currently ongoing, looking at the activity of axitinib in this setting, and those results are currently pending. What about using pre-surgical therapy in the setting of metastatic disease as a litmus test to predict who should undergo cytoreductive surgery? Well, back in the days of immunotherapy, and I'm talking about the old immunotherapy such as IL-2 and interferon, Axel Bex published on 16 patients. 5 patients had progressive disease with the regimen that you see, and thus were spared a nephrectomy that they were unlikely to benefit from. As you can see, their median OS was only 3 months. He also reported on a prospective study with interferon alpha alone, and of 16 patients treated, half of them had progressive disease, and again were spared a morbid nephrectomy they were unlikely to benefit from with an OS of 4 months. Eric Yonash reported on patients treated prospectively with bevacizumab. Of 50 patients treated, 6 had progressive disease, and again were spared a nephrectomy they were not likely to benefit from, using that as a litmus test to select patients for cytoreductive surgery. And then Tom Powles published on 100 patients who were treated prospectively with pazopanib. 16 of them had progressive disease on therapy and therefore were not taken for cytoreductive surgery. And you can see that their median OS was only 3.9 months, indicating that they too would not likely benefit from a cytoreductive nephrectomy. We recently conducted this study that's outlined here, with the PI being Pam Sharma, where in the setting of IO therapy, patients were randomized to either receive nivolumab alone, nivolumab with bevacizumab, or nivolumab with ipilimumab. And in those patients who either demonstrated stable disease or some form of response and were still thought to be a surgical candidate, were subsequently taken for cytoreductive surgery, followed by maintenance immunotherapy after surgery. This study literally is in the throes of being published. It's been submitted for peer review. I can't really talk about the results at this point, but suffice it to say that this, I believe, also may be an effective regimen in the pre-surgical setting to better select patients for cytoreductive surgery. There's not a lot of cytoreduction with these therapies. However, there does appear to be significant activity in terms of anti-tumoral activity. What about safety? Well, we've published significantly on this. But just to go through different studies, Eric Yonash reported a 20.9% wound dehiscence rate with bevacizumab. This is probably one of the highest ones in the neoadjuvant literature. Sorafenib in the pre-surgical setting, no delayed wound healing. Sunitinib, 13% delayed wound complication. Axitinib, we had a 4.2% superficial wound complication, but no dehiscences. And pazopanib, the reported wound healing complication rate is about 4%. Many years ago, Brian Chapin, who's now a member of our faculty, reported on the use of targeted therapy in the pre-surgical setting. What we did was essentially compared a group who underwent upfront cytoreductive surgery to a group of patients who were treated with pre-surgical therapy, predominantly sunitinib. And we found no difference in the complication rate between the two groups, no difference in the Clavian grade 3 or greater complication rate between the two groups. However, we did see a significant increase in the number of wound complications in the group that received pre-surgical therapy relative to the group that was treated with upfront surgery. Finally, I'd like to report our phase 2 trial at MD Anderson. Again, this was published several years ago, but highlights the significant activity of axitinib in the neoadjuvant setting. This was the first neoadjuvant study ever conducted in absence of metastatic disease. Here's the trial design. Basically, patients with T2 to T3B clear cell renal cell carcinoma that was biopsy proven, who were thought to be surgical candidates, were treated with 12 weeks of axitinib and then taken for curative nephrectomy with RPL&D. You can see the primary and secondary endpoints. And virtually every single patient had a response to therapy. The partial response rate was 46%, which is the highest reported in the literature, with 11 patients having a partial response. 12 patients were reported as stable disease, although they did have a minor response. And again, nobody had progressive disease. One patient had to stop treatment 1 week early due to toxicity. We've gone on to publish several studies that are associated with this clinical trial that you can see listed here, basically looking at anthropometric parameters, looking at the kidney tumor parenchymal interface after neoadjuvant therapy, and also looking at the inter-observer agreement on feasibility of partial nephrectomy, which, as I highlighted earlier, is a very subjective endpoint to try and see if that could be used as a reasonable endpoint for a study if there was inter-observer agreement. So I'd like to finish off with a case. This is a case of mine, 55-year-old white male who presented with left-sided abdominal pain. His past medical history was for hypertension and urolithiasis. You can see the CT chest was negative. He had some red cells in his UA, but otherwise his labs were within normal limits. And you can see that he has a locally advanced tumor invading the right lobe of his liver with significant invasion. You can also see, incidentally, that he also has a large stone in the left kidney, which likely was the cause of his presentation pain. Again, extensive involvement of the right lobe of the liver by this very invasive tumor, shown here as well. So I went to our liver surgeons and asked them, you know, is this feasible to be resected? And unfortunately, the patient did not have enough mass in the left lobe of the liver to allow for right hepatectomy to resect this lesion. So by the liver surgeon's criteria, this lesion as it stands is unresectable. So we elected to do a few maneuvers to try and make him more resectable. He underwent a biopsy, which showed clear cell renal cell carcinoma, Firm's grade 2, which probably is undergraded. He underwent right portal vein embolization to induce left hepatic hypertrophy, which would require some time, 8 to 12 weeks. And so we elected to treat him neoadjuvantly with axitinib 5 milligrams twice a day. And he was treated for 10 weeks. And you can see the response was quite remarkable with significant tumor reduction size. And also you can see the central necrosis that is associated with the response to TKIs. You can also see the coil here in the portal vein where they did the embolization with good hypertrophy of the left lobe of the liver, allowing resection of a small portion of the right lobe of the liver with adequate hepatic function after surgery. There's, again, another look at things. So you can see that there was a significant reduction in the amount of liver invasion as well as anti-tumoral activity primarily in the primary tumor. So the patient underwent a right radical nephrectomy with RP-LND and a right partial hepatectomy. We also performed cystoscopy with left ureteral stent placement to avoid the postoperative issues that might be associated with passage of that stone in his left kidney. And you could see the final pathology listed there. There was viable tumor present in the specimen. However, there was a significant amount of necrotic tissue as well. So these are my take-home messages for neoadjuvant therapy for locally advanced and metastatic renal cell carcinoma. Is it safe? Yes, although there is the potential for wound complications, which should be considered during the time of surgery, and modifications in wound closure might be warranted. Can it shrink primary renal tumors? Yes. Can it convert a radical nephrectomy to a partial? I would say sometimes. Can it make unresectable tumors resectable? Again, I would say sometimes. And again, those both are very subjective endpoints. Does it downstage IBC tumor thrombi? I would say rarely, and should not be counted on and should not be considered a standard for patients who present with an IBC tumor thrombus. Should we use it routinely off clinical trial? And I would say most definitely not. At this stage of the game, I still think that the only indication for using neoadjuvant or pre-surgical therapy off clinical trial is in patients who are not surgical candidates for whatever reason that might be. Can it help selected patients? I believe it can and will. With further study, and do we have more work to do? Do we have further studies that need to be conducted? I would say absolutely yes. So with that, I will conclude, and I'll stop sharing my screen. I'm happy to answer questions, or if you want to save questions till the end, that would be fine.
Thank you so much, Professor Wood. I thought we'll assimilate all the three presentations and then request for all the questions. There are quite a few questions in the chat box. One of the questions is the incidence of renal cell carcinoma truly increasing, or is it a relative increase because of imaging, is what they're asking. And there are a couple of questions based on IVC thrombus, which I think will be better answered after Dr. Amlesh Seth's presentation. So I'm going to request Professor Seth to start his presentation now.
Is my screen visible?
Yes, sir. We can see your windows. I think it will be better if you open the PowerPoint itself, sir.
I have opened the PowerPoint.
Sir, PowerPoint is not seen, sir.
It is showing your screen sharing.
So the screen which you have shared is probably a different screen, sir. You need to unshare that and go back and share the PowerPoint screen, sir.
Okay, I'll go again.
For the faculty, sir, I can hear you, but we are not able to see the screen yet. You need to share the PowerPoint screen, sir.
Okay, I'm doing the same thing. I'll do it again.
Yes, sir.
Just.
What I'll do is I'll type some of the questions into the chat box so that the faculty can think about the questions that are being posted in the QA box.
Okay.
Sir, please click on the PowerPoint now, sir. See whether that starts off.
Yeah. Can you see it now?
No, sir. We are not able to see the screen. We are just seeing Windows with 4 videos and a PPT.
Sir, do one thing. Stop sharing right now.
Okay.
Now, when you click on share screen, right?
Yes.
Highlight screen. Select the.
I have highlighted the screen. Yes.
Yeah, and then click on share again.
Yes. Can you see it now?
Yes, I can see your screen now. Open. Now open
the PPT, sir.
Is it fine now?
It's not, sir. Sorry, I'm just going to tell it one more time, sir. Sir, open the PPT. Do not completely make it full screen. Keep it at half screen, and then go to the screen share button and then click on the PPT, sir. What's happening is that it's touching on the Windows, not the PPT, sir.
Okay.
Yeah, you can stop sharing.
Can you see it now?
Not yet, sir. You can stop sharing.
Do we have sir's presentation with us? Can we play it from our computer?
No, sir. If you click on share screen now, if the
Yes.
presentation is open, you can select the presentation directly. So click on the presentation in the pop-up box.
Yes, sir.
Yes.
We are on now. Yes, sir. Thank you.
Okay. So thank you, everybody. When Sudhir rang me up and he said, you have to talk on this, I said, I have already talked about it on so many occasions. But when he told me the entire program, I said, yes, I cannot stay away from this. And I looked at the whole program. It looked very interesting. And I really feel honored to follow Dr. S. Ward, whom I know for the last 15 years. He has been a great friend and a well-wisher. RCC with IVC thrombus, how do I handle? We all know that 10% of the cardiac output flows through each kidney, and this percentage increases significantly in a patient who has a large renal tumor. And when the outflow is obstructed because of the venous thrombus, it adds a lot to the problem, and therefore early arterial control is highly desirable. The method of early arterial control is well described in Campbell's urology for the last almost 30 years. The landmark is the inferior mesenteric vein in the posterior peritoneum. You have to incise the posterior peritoneum just to the right of the inferior mesenteric vein, and you will come across the left renal vein after just taking off a little bit of areolar tissue. And once you identify the left renal vein, you have to dissect the left renal vein and sling it up. And behind that, you will find the aorta. And for right-sided tumors, you have to stay on the right edge of the aorta to identify the right renal artery. And for right renal tumors, this first step is the most important and most essential step. For left-sided tumors, also this is extremely important and extremely essential. But sometimes if there are lots of veins, it becomes difficult. And therefore, in that situation, occasionally I have resorted to preoperative embolization of the left renal artery. But on most occasions, one can identify the artery early and control it. And that's the first extremely important initial step. The lower level thrombus, I am not going to talk much about because these are relatively straightforward. We need to dissect the IVC above and below, and we need to clamp. The left-sided tumors are always more difficult. They bleed more. And sometimes just clamping the right renal vein may not be adequate. And if the right renal vein swells up, it is also desirable to clamp the right renal artery for those 15 minutes or so when you have opened up the IVC. And it is also desirable to control as many lumbar veins as possible because lumbar veins also lead to a lot of bleeding, a lot of venous inflow into the IVC when the vena cava is open. There's a lot of bleeding that goes on. And the vena cavotomy should be as small as possible and just enough to wriggle out the thrombus because the IVC keeps on bleeding till the entire IVC is closed back. And therefore, if you have a small vena cavotomy, the earlier you have a shorter duration of controlling it, and therefore blood loss is less. In the retrohepatic, I generally divide the level to an upper level or a lower level. Lower level means that there's at least a 2 centimeter gap between the point where the hepatic veins are opening into the IVC. And in those situations, I always get a Doppler ultrasonogram done one day before the surgery, and I ask the ultrasonologist to measure the exact level between the hepatic veins and the upper level of the IVC thrombus. And if the distance is more than 2 centimeters, then we can go from below. And what we need to do is to dissect the IVC from below. There are small veins that are present in there are small veins that drain from the caudate lobe of the liver and the segment 5 of the liver to the IVC, and they're invariably only anterior and lateral. There are no veins posteriorly. And anterior and lateral veins, the plane is reasonably good. One can quite easily dissect and one can go deep, high up in the hilum. And once one reaches above the level of the thrombus, then all that one needs to do is to clamp above, clamp below, and clamp the opposite renal vein. And then after that, it becomes a relatively straightforward surgery. As I mentioned earlier, the vena cavotomy should be as small as is needed to wriggle the tumor out. For a higher level, you have to mobilize the liver, and suprahepatic control of the liver is an extremely important step. And once a suprahepatic IVC is dissected and ready to be clamped, one needs to clamp the porta hepatis and do what is known as the Fingal's maneuver. And then one needs to clamp the IVC below the opposite renal vein and then the suprahepatic IVC. And once these things are done, then the vena cavotomy will be reasonably bloodless and one can wriggle out the thrombus and then suture it. But sometimes for reducing the ischemia time to the liver, at this step, after putting all the cross clamps, when the thrombus shrinks a little bit, one can very quickly do an intrahepatic section and put a clamp higher up in the hilum, as has been done in the previous case, as was shown in the previous video. And then one can convert it into a surgery which was like in the previous video. And if the IVC below the thrombus is totally occluded by a bland thrombus, then in that situation the IVC needs to be divided and dissected and ligated. Otherwise, there would be a pulmonary thromboembolism in the post-op period. The next video actually demonstrates all the three things, and this is what I'm going to show in this video. In the first step, we are seeing the dissection of the liver, the dissection of the IVC above the liver. So the liver has been retracted down, and all the connections of the IVC, of the suprahepatic IVC, are being mobilized. And now you can see that this is the hepatic surgeon who is doing this, and he has put a sling above around the IVC in the suprahepatic area, and the IVC is ready to be clamped. So once the IVC is clamped, then Fingal's maneuver should actually be done before. Fingal's cross clamping is required before the suprahepatic IVC clamping, and in this case, after we have excluded the venous circulation by clamps above and below and opposite renal vein, this is the intrahepatic dissection of the IVC that is going on, and because we wanted to get to the upper edge of the tumor. So with this intrahepatic dissection, now you see that high up in the hilum of the liver, we have put a clamp, and there is a big thrombus which is invading the wall of the thrombus, which is invading the wall of the IVC, can be palpated. And once there is a clamp in the hilum high up, you see this IVC is actually cutting like a fibrous tissue, and there is a thrombus which is invading the wall. So the entire IVC had to be excised, and there's just a small part of the IVC that is remaining, which is just draining the left renal vein. And so this, in one case, I had to ligate the left renal vein at its ostium also. In this particular case, just a small stump remained, and this is the closure of the stump of the IVC in the hepatic hilum, and which is connecting the left renal vein. And the IVC below has to be divided and sutured. In this video, we'll just see the suturing of the lower part of the IVC after this. Yeah, this is the closure of the lower IVC, because this lower IVC is completely filled with a bland fibrotic thrombus. For suprahepatic level, if it is going into the intrapericardial, if it is just short of the atrium, then one can get an intrapericardial control. But for right-sided, this can be done by a thoracoabdominal approach. But for a left-sided one, you need a long midline laparotomy and a mid-sternotomy. And therefore, left-sided tumors are always more difficult. This is a left-sided tumor. The thrombus going above level of the hepatic veins, but short of the atrium. And therefore, this was done by a long thoracotomy and long laparotomy and intrapericardial control of the IVC. Once you open the pericardium, the cardiac surgeons, they can, the planes are very good. They can very comfortably put a finger around the IVC, which is within the pericardium. And this is the specimen that we got. And for a high level thrombus, as per the literature as was described by Andrew Novick's team, and that technique has been followed quite commonly all over the world, and that has been what is described as cold hypothermic, deep hypothermic circulatory arrest with exsanguination, which means that the patient is put on cardiopulmonary bypass, and then the patient is cooled to a temperature of 18 to 20 degrees centigrade, and then the patient is exsanguinated. Exsanguinated means that the arterial inflow is stopped, the venous outflow continues, and then under a more or less exsanguinated situation, the heart-lung machine is also either stopped or the flows are brought down to about 100 ml per minute, which is actually a very low flow, basically barely enough to maintain the CNS blood flow. But we have modified this technique. We put these patients on cardiopulmonary bypass. We cool them to a temperature of 31 to 32 degrees centigrade, which is mild hypothermia. And we carry out a partial circulatory arrest by cross clamping of the supraciliac aorta. And this also provides us a reasonably bloodless field in the area that we are going to operate. And this leads to a preservation of the blood supply to the CNS, the coronaries, the bronchial and upper limb vasculature. So this is the video. A left-sided radical nephrectomy has been done. IVC below is soft, and IVC above is full of tumor. So this is the thoracotomy and pericardiotomy being done, and this is the dissection of the supraciliac aorta. The crura of the diaphragm, they have to be separated, and the supraciliac aorta can be identified there. Once the supraciliac aorta is identified, it can be cross-clamped by a Crawford clamp. The bone behind also provides some kind of a support. And once that is ready to be clamped, this patient is being put on cardiopulmonary bypass. And after bypass, the patient would be cooled to a temperature of 31 degrees centigrade. And this is the inferior vena cavotomy being made. And there is a sucker that has been put in the IVC below. You can see there is a sucker in the IVC below. This sucker is a pump sucker, which is sucking the blood into the cardiopulmonary pump into the heart-lung machine. And this is a thrombus that has been caught, and the thrombus is being delivered from below. And one can have a transesophageal echocardiography to check whether thrombus is completely removed or not. And there is some part of the thrombus that is still remaining in the atrium. So this is the atrium that has been opened, and the thrombus is being pulled out from the atrium. And after being pulled out, there are some tags that are remaining. So you can see the sucker that has come from below up into the atrium. There is a gauze peak being pushed from the atrium above into the IVC below, and it is being retrieved from the IVC below. So once complete thrombus removal has been done, this is now closing back and warming the patient slowly, and reversal of the cardiopulmonary bypass. Thank you very much. I'll just talk next 2 or 3 slides talking about our experience. And in the last almost about 15 years, we have done about 98 cases with a median survival of 54 months in level 1 and 2 and a median survival of 42 months in level 3 and 4. For a level 3 thrombus, the mean operating time has been from 210 to 330 minutes, and mean blood loss has been relatively low, and we needed blood transfusion in 3. 30 days, 2-day mortality was 2. And this is an experience of 23 patients who had a level 4 or intra-atrial thrombus that were done on cardiopulmonary bypass. The bypass time was about 53 plus minus 9 minutes, and aortic cross clamp time, which is quite critical, was about 18 minutes plus minus 2. So we can actually do the entire thing from 16 to 20 minutes, and we lost 2 patients in the perioperative period. And in this follow-up period, the median survival has been 42 months. We obviously have the support of a long list of people. The cardiac surgery people are involved, the anesthesia team, the ICU team, the hepatic transplant team, everybody is involved, and then only one can do these procedures. Thank you very much.
So thanks so much, Professor. I'm going to request the next speaker, Professor Makram Kochikar, to start his presentation. whilst I will request all the three faculty to have a little look into the chat box where I posted the questions from the audience, and if you can, some of the questions have been answered, but the ones which are not answered, kindly give us a quick overview at the end of this presentation. Thank you so much, sir.
Hi everyone, can you see my screen?
Yes,
Hello,
sir.
everyone.
We can go on to the PPT presentation, sir. Thank you, sir.
Yeah, can you see my screen?
Yes, sir.
Yeah. First of all, thank you very much for the kind invitation. The entire team of Society of Generative Urinary Oncology. It's a really pleasure to be part of this. And as been mentioned before, I think we are standing on the shoulders of people like Dr. Srinivas, Dr. Jagdish Kulkarni, Dr. Murli Kamath, and Sudhir and myself joined the band almost in late 90s, and it's been a pleasure to see the progress of urological oncology. Now, the task which is given to me is N+ disease in renal cell carcinoma. How should we treat? First of all, when I look into N1 disease, how do you define N1 disease? We have to rely on AJCC cancer staging way back in 2016. That's the latest we have. And what does it say? That N1 is metastasis in the regional lymph nodes. That is what it says. It doesn't say the number of lymph nodes. It doesn't say about the volume of the lymph nodes involved. It doesn't tell you the template which is involved. So when you talk about managing N1 disease in RCC, it's a plethora of conditions. How do we assess lymph nodes in RCC? We rely mainly on CT and MRI. And many times, when you're doing radical nephrectomy, if you feel lymph nodes are suspicious, then you go ahead and try and make a further decision, which will elaborate in my presentation. What is interesting, if you look at the literature, both CT and MRI are unsuitable for detecting the malignant disease in the nodes in a normal shape and size. We don't do FNAC, that is not a standard of care. We don't do biopsies of the lymph nodes to prove there is a metastasis. And we all know PET-CT has a poor sensitivity. Even though you suspect these patients have lymph nodes intraoperatively, when you do lymph node dissection, you can have as low incidence as less than 4% to something like 20%, but the incidence is pretty low. So in a given case of RCC, when we're going to talk about lymph node plus disease, is 4 scenarios I think of. Imaging an intraoperative suspicion, but we're not entirely sure about it. Probably there is a possibility of micrometastasis. The second scenario, on a CT scan or MRI, you see multiple medium-sized lymph nodes on imaging, or when you explore, sometimes you see intraoperatively, possibly this is a scenario where there's a strong possibility of lymph node positivity. If you take the further sort of a stage where we have large retroperitoneal lymph nodes, we are pretty certain, then what's the management in this case? And obviously, when you have lymph nodes and a distant metastasis, that may not be a sort of a subject of this talk, but I think this is another entity. So let us take this scenario after scenario and how best we can manage. So let us take the first scenario. You've done the imaging, the intra imaging, and you find possibly imaging suggests that there is possibility of lymph node enlargement on a CT or MRI, or you explore and you see a fair amount of lymph nodes of sizable size intraoperatively. Then what do you do in this? I'm sure radical and partial nephrectomy as indicated, one should go ahead. Then the question comes, are we going to do lymph node dissection in these patients? There is huge amount of literature on this, whether that is useful, whether it is indicated, does it have survival benefit, and majority of studies, EORT study, retrospective studies, and recent sort of meta-analysis suggest that there may not be survival benefit. If at all you decide to do it, there is a little bit of confusion in which template is the ideal one. What I feel that if you see a patient who has T1, T2 clear cell renal cell carcinoma, he has no high risk features. I'll explain you what high risk features are. Probably in those situations, even though you have suspected on imaging or intraoperatively, these patients would not need a lymph node dissection because there would not be a positive yield. But if you have a high risk features, the lymph node dissection may be helpful as a staging procedure, and maybe in a small percentage of cases, it may have therapeutic benefit. That's a big query. What are the risk factors of lymph node metastasis, and when do you make a decision of doing lymph node dissections? You look at the statistic. This is one of the study I liked from Japan, which was published way back in 2005. If you have T1, T2 disease, V0 is no venous thrombosis, the lymph node involvement is about 13%. If you have T3 disease, no venous involvement, 33% of the patients would have lymph node metastasis. And if you have T1 to T3, but venous thrombosis, as Amlesh has shown, half of these patients would have lymph node metastasis. This was a wonderful paper which published by Crispin in 2011, and they established the risk factors by doing a lot of case studies. And they found that tumor which is more than 10 centimeter, patients who have T3, T4 disease, venous wall involvement or venous thrombosis, necrosis, high Fuhrman gate, and cyclometer histology, these are the patients perhaps you can think of doing lymph node dissection intraoperatively when you explore these patients. And this was a study which suggested that nearly 38% of the patients had lymph node metastasis. All of them had lymph node involvement in the hilum, in the first lymphatic site, and subsequently went into the retroperitoneum. And as you keep on adding the risk factors, if there are more than 2, 3, 4, more the high risk factors, more chance of lymph node metastasis. I mentioned to you about EORT study. This EORT study did mention that it may not have therapeutic benefit and it may not be necessary to do lymph node dissection. But what are the real facts of this EORT study? The lymph node dissection combined with radical nephrectomy, what they concluded, does not increase the morbidity and mortality. We all know about it. Its efficacy in terms of prolonged progression-free survival could not be demonstrated, mainly because of the low number of lymph node metastases direct on lymph node dissection. This does not mean lymph node dissection should be completely abandoned, but in individual cases, perhaps the aggressive disease and high-risk patients, it should be make a case for doing lymph node dissection. It is interesting when you read this editorial on EORTC study, which was published in European Urology. Heinemann Poppel said it is not an absolute in clinically node negative patients. And Urs Studer, a good friend of mine, does suggest that I think you can think about doing it in high-risk individuals. If you make a decision, yes, you want to do lymph node dissection, what is the template? Is it a hilar, complete ARPLND, where to start, where to finish? I think you can do a standard hilar lymph node dissection in a right-sided radical nephrectomy, which I have depicted here, or you can do a standard template. I'll explain you what it is. This is a left-sided radical nephrectomy, and you have done left para-aortic, hilar, intra-aortic KL, and a pre-cable. And this is done on the left radical nephrectomy. This is a template. You all know about possibility of lymph node metastasis in the right-sided renal carcinoma. You will get a pre-cable, para-cable, intra-aortic cable, and pre-aortic, but nothing on the left-hand side. And similarly, on the left-hand side, you can use this template. This tells you the incidence of lymph node metastasis in this scenario. So you can do that. Second scenario is when you have medium-sized hilar lymph nodes, retroperitoneal lymph nodes on imaging or intraoperatively, like this case. A large patient tumor with a lot of necrosis. You can see a lot of lymph nodes in the retroperitoneum. And when you actually do a nephrectomy, you dissect out the specimen, you see a lot of hilar lymph nodes. I think you can do extended lymph node dissection in these type of cases. If you get N0, maybe they have better outcome. It does not add morbidity and mortality. Minimum number of lymph node dissected according to EU guidelines is about 15. And this is what it was done in this case. And almost it turned out to be PT0. Now, this is supported by a paper by Cappuccino. We showed about lymph node dissection in renal cell carcinoma. And what they concluded that if you have more than 4 lymph nodes with extranodal extension, then perhaps these patients may not do as badly as possible. But if you have lymph nodes of less than 4 centimeters, these patients do very well. This was another paper looking at the survival based on SEER data. And SEER data does suggest that if you do more number of lymph nodes, more than 10 lymph nodes, then possibility that you will give survival benefit or therapeutic benefit in these kind of patients. So what does the guidelines say? The guidelines say that involvement of the intra-aortic or lymph nodes, regional or hilar, is reported is about 35 to 45%. And sentinel lymph node is an investigation part. And the guidelines do suggest that survival advantage is not demonstrated. Retrospective studies show clinical benefit associated lymph node in a high-risk patients. So the recommendations is you can offer lymph node dissection with adverse clinical features, including large diameter of a primary tumor. But what is important is this has to be supported by the literature. I came across two papers which were just recently seen in BJUI. This was a systematic review and a meta-analysis, and this does suggest that small percentage of patients PN1M0 may have durable long-term oncological outcome and survival rate in the range of something like 21 to 30%. But you have to choose very, very wisely. And this was another meta-analysis which suggested multi-institutional study that yes, you can use in high-risk patients, but it cannot be translated into therapeutic benefit. But certainly for a low volume disease, it is useful. So in summary, just last few slides, the recommendation is we clinically enlarged nodes, perform lymph node dissection as a staging purpose for a local control. Last two conditions, large bulky lymph nodes, imaging, and intraoperatively. What do you do there? There is no metastasis. As Professor Wood has shown, you can use neoadjuvant therapy, but it's basically to downsize the primary tumor, downsize the IBC thrombus, and downsize the metastasis. But there is no data on suggesting whether you can downsize the lymph node mass itself. Probably it's sort of seen in these all metastatic cases where there is lymph node metastasis, but there is no single study which quantifies how much benefit you get in a lymph node regression. Whenever you get this large bulky disease, look for distant metastasis. And if that is the case, don't go ahead with the lymph node dissection. You can choose cytoreductive nephrectomy upfront or adjuvant therapy depending on the situation as such. Lastly, if you have a retroperitoneal lymph nodes with distant metastasis, obviously you're going to treat them as a stage 4 disease. What do we do when we find in the final histology PN1 disease? Do we observe? Do we give them systemic therapy? And I think there's a $1 million question. And wherever there is a talk on adjuvant therapy, I'm sure this part is covered. But as of today, the international guidelines do not recommend using an adjuvant therapy as a standard of care when you find a lymph node positive disease. Thank you very much. I hope I stuck to the time.
Thank you so much, sir. Really appreciate your presentation. That brings the end of the first session. There are a lot of questions in the chat box, and the faculty have been very kind to answer them. Just to summarize some of the questions and the answers that we have got through, as regards the choice of neoadjuvant chemotherapy, Professor Wood hasn't expressed any particular interest or any particular preference, but I think from the looks of it, axitinib will be a good choice, but the cost will be a prohibitive factor. Looks like we don't have a particular choice of therapy. Anything should be okay, because that field itself is an expanding field as the day stands. Ganesh Bakshi has asked a question to Professor Amlesh Seth about the type of thrombus and how would you take it off. He says the porridge type 1, how will you take it when the forceps is not holding right? I would request Amlesh sir to answer that question. Right renal artery occlusion, it's preferred not done, but if there is a need to do, if you can do it within 10 to 12 minutes, it will be good. Not exceeding 15 is the expert's opinion. The best and fast surgery is a better thing to do without occluding the right renal artery. Lumbar veins ligation, it's not mentioned, but generally lumbar vein ligation will not cause a great deal of problems. If there is a need to ligate, you can ligate, or if you dissect it well, you can put a little bulldog and carry on the surgery and open the lumbar veins afterwards. I think I have answered all the questions. There was one question on IVC filters. Can I ask Amlesh sir to answer those questions, please? And then with that, we'll finish this session.
Can I ask? Thank you, Dr. Raghavan.
Yes, sir.
So the questions that have been asked regarding the IVC thrombus, the first question regarding the porridge type. Actually, the thrombus can be of a very variable type. There are some thrombi that are very soft and they just fragment on holding. For that, you actually need a bigger vena cavotomy and you need to dissect it off either with a peanut or sometimes even a gauze piece. One can take a gauze piece on one's finger and one may need to sweep the IVC from inside. So that is one thing, especially in the last video that you saw, there were some tags that were remaining and that actually needed to be swept off by the gauze piece. And the other question of clamping the right renal artery, and again, some of the thrombi would be invading the IVC wall and that part of the IVC wall will need to be taken out. Some of the thrombi will come off very easily. I think it has something to do with the primary histology, whether it is a clear cell or a sarcomatoid variety or it is a peanut. peanut, I have seen they are more fleshy and they come out more easily, but they are more friable also. Regarding the clamping of the right renal artery, it is mentioned in the book, but it is not easy to do because in left-sided tumors, the left renal vein is significantly dilated, the IVC is dilated, and the right renal artery is behind. To lift it off, you're always scared that you may fracture the thrombus and lead to pulmonary thromboembolism. And but at the same time, clamping the right renal vein is also not adequate because there is a good amount of flow that is going into the right kidney and it is not coming out. And rather, it will actually come out from the adrenal vein, from the gonadal vein, from the retroperitoneal veins back into the IVC, and there will be a lot of bleeding. So left-sided thrombi, they have to be done very, very quickly. Your assistant has to be very good. What I generally do for left-sided is that I put my hands on the IVC and try to control as much bleeding as possible. And there is one person who is sucking the blood all the time. And my first assistant is suturing the IVC as fast as possible. Because that is something where each and every minute, I would say every second is important. Again, regarding the lumbar veins, it is easy to say that they should be clamped. But because the IVC is extended and the renal vein is extended, finding the lumbar veins behind is difficult. In an RPLND, one can find the lumbar veins very easily and one can tie them, double tie them, divide them. But in an IVC thrombus, they are difficult. Again, the way, if you can find as many as you can see and you can ligate and divide, that is good. But if you cannot, then the only option again remaining is that when the vena cava is open, suture it up as quickly as possible. And all this procedure actually does not take more than 10 or 12 minutes because all that you have to do is open up the vena cava, sweep the inside, and sew it up. There should be pre-placed stitches that should be taken so that you can pull the IVC. The main surgeon, what I do is I pull the IVC up so that blood loss is less, or I control with my hand, and my first assistant quickly sutures it up. Because time is extremely important. I think all the three questions have been answered.
Yeah, can
Thank you so
much. Do you use
I think this discussion will not end because we have to move on. So
sir, with this, I'll bring the end to the session, and then Ginil can take over.
Yeah,
so a lot of questions coming through the chat box. I have put the questions.
Yeah, it is
here.
better than we
The
go to next
faculty
session.
can
We can come in panel discussion. During
Yes.
panel discussion, we can discuss some more.
Thank you so much, sir.
Please
Thank you.
invite the. Yeah, sure. Thank you.
Thank you, Raghavan. Thanks, Raval sir. It was a great opportunity for me to share the screen with a lot of eminent faculty across the globe and from India. After the excellent discussions about the locally advanced tumor, we are moving on to metastatic renal tumors. In the metastatic renal tumor, we have got two sessions. One is medical management, followed by surgical management and radiation therapy, what is possible in renal tumor. So next session, we have got a few of the eminent faculty of our country as chairpersons. I invite Dr. Nitin Kekre and Anish Srivastava, the two great academicians of our country, Shekhar Patil, the well-known medical oncologist from Bangalore, and Rajiv Sood, ever dynamic leader of our Urology Society of India and the leader for our academic programs in the USI. So please take the chair and introduce. We have got three talks in this session. I invite the chairpersons to take the chair and start the proceedings. Thank you, sir.
Thank you very much.
Yeah. Okay.
Thank you very much, Dr. Jinil. I think it is very important that we are discussing the medical management of a metastatic renal carcinoma. When I joined my career, the only treatment available was Provera, which never worked. And from then on, today the scene has completely changed. And today the metastatic renal carcinoma is there are many options of treatment. And they depend on a lot of factors. And with this, I invite the first speaker, Dr. Amit Joshi, who is going to take us through the risk stratification in managing the patient metastatic RCC. Dr. Amit Joshi, please.
Good evening, everyone. Am I audible to everyone?
Yes, you are audible.
Yes, yes.
My screen is visible?
Yes, very much visible.
Yeah, so I will just go through the risk stratification in metastatic RCC. So I think the various risk stratification model which have been used are the most common is initially is the memorial stone cluttering model, then the IMDC model, and there are other models which have been in practice are the Cleveland model, the updated French model, and International Kidney Cancer Working Group model. But among all these 5 models, the most common and most useful are the initial 2, the MSKCC and IMDC. These are the clinically used, and there are other models which are being still not in use, but in future they are being used, and they are the genomically annotated risk model for advanced renal cell carcinoma, and the other that is known as Emory stratification that is being used for patients who are being planned for the immunotherapy. So this risk stratification is evolving, and from the MSKCC, it has come to the genetically driven risk strategy modification. So this MSKC score, first most common, originally created in 1991, and then various inputs were added in 2008 and 2004. And then this model has also been extremely validated in other, and this was found useful. So this MSKC score comprises of the following factors, and everyone is aware of that: the time from diagnosis, the hemoglobin level, calcium level, LDS level, and performance status. And each of these factors giving the point of 1. And then depending upon this MSKC risk stratification, patient divided into the good or favorable risk, intermediate, and poor risk. This model was initially used in the interferon era, and there were patient divided into the, depending upon this risk factor on the 0 risk factor, 1 or 2 risk factor, that is intermediate, and more than and what they came in that era, the various survival among this group, that is good risk, intermediate, and poor risk, and what they found that this has been validated. But the problem of this was that this was initially used in the era when the interferon was used. With the available use of the various VGF TKI, there was a need of newer classification or newer risk stratification, and that was fulfilled by the IMDC or Hanks criteria. So this was a publication in JCO where this around 600 patients were stratified in various risk groups depending upon the initial time to diagnosis, KPS, hemoglobin level, calcium level, and then addition of the platelet and neutrophil was there. And depending upon the same, if there is no risk factor, it was a favorable risk. 1 or 2 risk factor, it was intermediate risk, and then the poor risk if there is more than 2 risk factor in that. So if you compare the MSKCC versus MRCC database consortium, the neutrophilia and the thrombocytosis, these were the additional risk factor which was added as compared to the MSKC risk criteria, and the LDS was removed from this. So what this model had addition of neutrophilia and thrombocytosis, which was a marker of the inflammation, and the LDS was removed, and this then came with this 6 point of the IMDC or Hanks criteria, which is very commonly used. This has been very well validated in more than 400 500 patients, and this was found that the patients who are in which the VGF TKI has been used, patients who are falling into the favorable risk have a median survival of around 43 months. Patient falling into intermediate risk group has a median survival of around 23 months, and patients who fall into the poor risk of this IMDC has a poor survival of 8 months. So this has been and this model has also been validated in future in other center, and it was found that this IMDC scores over MSKCC in risk stratifying the patient. So this IMDC determines the overall survival in patient treated with VGF targeted therapy, and this focus on receiving modern treatment in common practice. And unlike the other models, this also utilizes the neutrophil and platelet, which is also a established marker for inflammation. And this model, when compared with the other prognostic model at that point of time, that is Cleveland Clinic Foundation, the International Working Group, and the French model, this was found to be have a better correlation with the overall survival compared to the other model. So this IMDC was very commonly used. And with the availability of the newer therapies, this previously when this model was used, this was only for a prognostic significance, and there was no predictive factor, or the therapy was not being planned as per. But as the availability of the newer therapies come, this IMDC or Hanks criteria has also been used in making the decision. So patients who are being in IMDC favorable risk group, still the sunitinib and pezoprim are the still first drug of choice. You can combine the TKI plus oncology drugs in the first line therapy of IMDC favorable risk group. But those patients who are falling in the intermediate and poor risk, they are being preferred to use the combination of IO plus IO. So apart from the initial use of the prognostic, this model also defines the treatment plan in patients who fall into the intermediate and poor risk. Similarly, the NCCN guideline has also adopted the IMDC criteria in selecting the patient for first line of therapy. The patient falling into the poor and intermediate risk group will qualify for the combination of IO plus IO, or the combination of TKI, that is axitinib with pembrolizumab. So this model has again been very successfully used in the Checkmate 214 trial, where the combination of two immuno-oncologic drugs, that is nivolumab plus ipilimumab, and this has clearly shown that in patients who falls into this of poor and intermediate risk, has a clear-cut survival benefit in terms of 47 months of survival compared to the 26.6 months in the patient who fall into the so in patients who are having poor or intermediate risk group, the combination of IO plus IO being the standard of care with the use of this IMDC criteria. There was another criteria which was previously used when the temsirolimus was used in the management of RCC when this IO drug was not available. And in this model, the patients were selected out of 6. In these patients who having 3 or more criteria are selected and are classified into the poor risk group. But with the availability of this immuno-oncologic drug, this temsirolimus is being very less commonly used, and this model is not very commonly used in current scenario. Then comes the apart from this, we know that even patient who falls into the good and intermediate risk, there is a heterogeneity among the patient. Some patient even do better. So with this this same group of the Robert Modger, they came with another idea of adding the some specific mutation, that is BAP1, PBRM and TP53 along with the established risk factor. So what they did, along with the original MSKCC model, they added this TP53 mutation or BAP mutation, and in another group they added the PBM. Though these are the other tumor markers, specific genetic mutation present in the tumor cell. So they combined both original MSKCC and combined this mutation in the tumor cell. So what they concluded, that in patients who have this annotated MSKCC risk model, they found that this model better correlates the survival as compared to the MSKCC model. So in this model, patient, there was another category made of favorable risk. So in those patients who are in a favorable risk have a better survival compared to the MSKCC. And the C index, that is the yardstick for testing any other model, it was more close to the one, that is 0.637 compared to the original MSKC, which was 0.597. So what they concluded, that this mutation of this BAP1, PBRM1 and TP53 can be considered of adding in, but this model also needs the validation in this. So then came, since the use of novel and immuno-oncologic drug are very commonly in this era, so this group from the Emory University come with a novel scoring system which is exclusively used for a immune checkpoint inhibitor. So the previous model which we had was mainly for a VEGF inhibitor. With the use of immuno-oncology drugs, they came up with other specific criteria which includes the marker of inflammation, the body mass index and site of metastasis. So what they came with the Emory risk stratification system in which the MLR, that is monocyte lymphocyte ratio, less than 0.93 and more than 0.93, baseline BMI less than 24, more than 24, and the metastasis site. So they came with another model which is peculiarly used or specific to be used in patients who are using the immuno-oncology drug. And depending upon the model risk, they divided the patient into the 3 risk group, that is very poor risk group, intermediate group, and good risk group. So what they came with the result of this model in the patient who are being used immuno-oncologic drugs, they found that patient who fall into the very poor risk of group has a survival of 29.4, patient with poor risk. So this model further specified the use of different markers what has been used in the VEGF therapy, and what they concluded that the C status for using this model and compared with the IMDC, they found that their model predicted the survival better with a C status of 0.71 compared with the 0.566 by IMDC. So what they concluded that this model can be a better used in patients who are planned for immuno-oncologic drug compared to the IMDC model. But this definitely needs external validation in further comes. So what they concluded that these results should be validated in larger prospective study, but this had paved the way for a different stratification system compared to the IMDC system. Then came the another paper which looks like in the breast cancer there are certain specific genetic marker, various genomes which can be considered or a poor marker. So this group came with two different signature, that is clear code 33 and a 8 gene signature. So what they tested this clear code 33 gene along with the what other previous IMDC criteria, and what they came in with this specific tumor mutation model. They found that this group of the patient falls into the two risk group. They defined that group A and group B, and what they found that the patient who fall into the group B, CC group B, compared they did poorly compared to the group A, and they found that this was independent to the IMDC criteria. So they concluded that this model can be a better predictor model compared to the previous, but still this model still needs to be validated in further studies. So take home message: risk stratification in MRCC is evolving. IMDC is most commonly used risk stratification currently. IMDC has now both predictive and prognostic value. Various molecular genetic markers are evolving, including the TP53, BAP1, and clear code 33, and may be included in future risk stratification. With widespread use of immuno-oncologic drugs, newer risk stratification system is required and needs to be validated before widespread use in community practice. Thank you.
So thanks, Amit. You have nicely mentioned, starting from the MSKCC model where interferon alpha was used, to now the models which still need to be validated though for immune checkpoint inhibitors. So we'll have more discussion later on. So may I have the pleasure to invite our second speaker for the session, who will be talking about the most important issue which is going around about the immunotherapy. And Professor Nazir Renal is from the MD Anderson, and I invite him to present his work. Professor Nazir, please.
Thank you very much for the kind invitation, and congratulations on forming your Uro-Oncology Society. It's a pleasure to share with you some of our research as well as the latest landscape of metastatic RCC therapy. And I would like to share my screen here. Where is that? Not this one. Share screen.
We can see your screen. Just put the title slide up.
Slideshow. Yeah.
Okay. Do you see the screen?
Yes.
Yes.
Yes. Yes.
All right. So the title of my presentation is Advances in the Treatment of RCC with Immune Checkpoint Inhibitors and Target Therapy Combinations. Sudhir asked me to speak about is there a role for TKIs still in the era of now immune checkpoint inhibitor therapy, and then we'll see now how this fits now in the evolving landscape. These are my disclosures. So this is the timeline of approvals of therapies for renal cell carcinoma in the US and in Europe. And you see at the bottom a box with the different classes of agents that we've had now since 1992 when high-dose IL-2 was approved. And then subsequently, we had a drought of 13 years from 1992 till 2005 when the first target therapy was approved, and that was sorafenib. But over the years now, sorafenib has fallen by the wayside now, and then you have many new therapies, including target therapies. And lately here in 2019, we have two regimens that were approved combining an immune checkpoint inhibitor, pembrolizumab and avelumab with axitinib. And you heard from Dr. Wood about axitinib and its role. So this is a summary of completed and reported phase 3 trials of immune checkpoint inhibitors in first-line therapy for metastatic RCC. I'd like to just mention that all these therapies that I will be discussing and the trials that led to the approval have really been focused on clear cell RCC, the most common type of RCC. And right now, I think it's fair to say that for non-clear cell or variant histology RCC, we are still using the therapies that are approved for clear cell in non-clear cell. And there is really no established, in my opinion, effective therapy for the variant histologies like papillary chromophore. But we still use those therapies that have been approved for clear cell RCC. So on this slide here, you see the 4 trials that were completed and reported in first-line therapy for metastatic clear cell RCC, with the top one here, Checkmate 214. And Dr. Amit Joshi mentioned about the Checkmate 214 and briefly the results, and I'll go in a little bit more details of the results of this trial. The Emotion 151 had atezolizumab PD-L1 antibody plus bevacizumab versus sunitinib, but this did not meet its primary endpoints and therefore was not approved neither in Europe nor in the US. Javelin Renal 101 used avelumab PD-L1 antibody plus axitinib versus sunitinib, and then Keynote 426 pembrolizumab plus axitinib versus sunitinib. It's important to note here that the comparator arm in all those 4 trials is sunitinib. And you can see here the endpoints in this column of these trials and the number of patients recruited. So now, starting with the updated results that I presented at ASCO GU just 6 months ago in San Francisco, and this is the overall survival and independent radiology review response in Checkmate 214 with a minimum follow-up of 42 months. Again, here we're comparing nivolumab, ipilimumab, the dual immune checkpoint inhibitors, nivolumab being the PD-1 antibody and ipilimumab the CTLA-4 antibody. And here is the study design. Patients had metastatic clear cell RCC, and they were randomized to receive either the nivo-ipi arm or the sunitinib. Doses and schedules shown here. Treatment was continued until disease progression or unacceptable toxicity. Here, you see the stratification. There were 2 strata used for randomization. One, the IMDC score, which we heard about from Dr. Amit Joshi, and then by region. And here are the key eligibility criteria used for enrollment. The primary endpoints were objective response rate, PFS, and OS, in intermediate and poor risk. Again, we heard what intermediate and poor risk mean, how patients have intermediate risk and poor risk disease. Secondary endpoint were ORR, PFS, and OS in the intent to treat population, the overall population, and safety. And then exploratory were, again, efficacy endpoints in favorable risk disease. There were 1,096 patients enrolled on this trial, and here are the Kaplan markers for OS for the primary analysis cohort or population, and that's the intermediate poor risk patients. And as you see here, on top is the curve for patients with treated with nivolumab, ipilimumab. Again, at 42 months minimum follow-up, 52% of patients treated with nivo-ipi were alive versus 39% with sunitinib. And then here, if to your right of the screen, you see the results of OS at different time points. The primary analysis that was presented at ESMO in 2017 and then published in the New England in 2018. Subsequently, at 30 months minimum follow-up, The results were published in Lancet Oncology last year, and now we just published the results of the latest update in JITC just last month. And here you can see the median OS for the nivo-ipi arm versus sunitinib at these different time points with minimum follow-up. And here is the latest. The median OS for the nivo-ipi treated patients was 47 months versus 26.6 months with sunitinib, and the hazard ratio was 0.66. As you note here, the hazard ratio has been about consistently in the 0.6 range these different follow-up times. Now, looking at the intent to treat, this is now all patients, 1,096 patients randomized. Results are very similar. But if you look here now, because you have now included patients with favorable risk disease, the median OS, again, at 42 months minimum follow-up has not been reached yet, but with sunitinib, it's 38.4, better than 26.6, which we saw earlier for intermediate risk, poor risk. And again, here is because we're including patients with favorable risk who usually have a longer survival. Now, what about the responses? And you see here in light green are the partial responses, and in dark green are the CRs, complete responses. And then here on this slide, you see this column here has the primary analysis population, and that is the intermediate poor risk patients. Here in the center are the patients treated. Those are the intent to treat patient population, and then the exploratory are the favorable. As you note here, across the board, nivo-ipi produces somewhere around 40% responses. But when you get to the favorable risk, the response is 29% for nivo-ipi, and it's 54% with sunitinib. But note that for CRs, which is here in dark green, for nivo-ipi, it's about 10%, 11% for the ITT, 10% for the poor, for the intermediate risk poor risk. And unfavorable here, although sunitinib has a higher ORR than the nivo-ipi for favorable risk patients, the CR rate is about double or a little bit more than double with nivo-ipi. And then here at the bottom is the median duration of response, again, for these different patient populations. With the ongoing response, higher percentage of patients have ongoing response treated with nivo-ipi. And then here, if looking at the progression-free survival Kaplan-Meier curves here for the intermediate risk, poor risk patients, as you note here, there is a plateau. There is a shoulder at the end or a tail at the end of the curve for the nivo-ipi arm, with about 35% of patients progression-free at minimum 42 months. And again, for sunitinib, you see the curve continues to drop. And this is really the most important, in my opinion, value of treating patients with nivo-ipi if they have intermediate risk poor risk disease. And that's the opportunity to have a durable progression-free time. And then we can talk a little bit later about the concept of treatment-free survival or treatment-free interval. That's the time when patients can finish therapy and still remain progression-free, as you can see here by the shoulder or the tail at the end of the curve for nivo-ipi. When you look at the median PFS for the intermediate risk poor risk patients, 11.6 versus 8.4 for sunitinib. The hazard ratio is 0.82 and p-value 0.03. And then this was at 17 months, the initial evaluation, and then the latest updated results, 12 and 8.3 with a hazard ratio of 0.76. Again, the 95% confidence intervals being under 1. Now, what about the PFS for the ITT? Similar to what we saw earlier for the intermediate risk poor risk, although here the curve is not totally flat as we saw before. And here are the median PFSs for the intent to treat patients population in by nivo-ipi treatment or sunitinib, and the 42 months minimum follow-up. Here you can see there is no difference in the median, but really that's misleading to look at just the median here. When you're looking at PFS, is what you really need to look at is the hazard ratio as well as the landmark analysis. Again, looking at the curves, how they separate, and how the nivo-ipi arm is almost quasi flat compared to sunitinib, which continues to drop to the x-axis. So now the question that is now facing everybody is: do we need to give nivo-ipi when we want to treat a patient with immune checkpoint inhibitors? And acknowledging that the nivo-ipi has been associated with a discontinuation rate of 22% with high immune-related toxicity compared to just monotherapy with a PD-1 antibody. There were several studies looking at the value of starting with just monotherapy with a PD-1 antibody and later adding the anti-CTLA-4. And here for comparison, you see that Keynote 427 was a trial with pembrolizumab, monotherapy in clear cell as well as non-clear cell. They had two cohorts. And the response rate was 36% with monotherapy pembrolizumab, but the CR rate was less than 3%. PFS was also around 7 months. Those three trials looked at nivolumab followed by the addition of ipilimumab. And you see here the ORR is variable, but really less than what you see with the combination of nivo and ipi, and then the PFS is lower. Now, the efficacy, I think, looking at when these three trials were presented at ASCO just a couple months ago, this year virtual meeting of ASCO, the results were really telling. And the message was from these three trials, the HCRN GU 2016-260 presented by Dr. Mike Atkins, the Omnivore presented by the Dana-Farber group, and the Titan RCC by Dr. Grimm from Germany. It was presented at ESMO. Those three are consistently showing that the addition of IPI sequentially later to Nivo is not as good as given IPI upfront in first line. So the message here, if we are going to use a dual immune checkpoint inhibitor, it's better to combine both the anti-CTLA-4 with anti-PD-1 upfront to achieve the higher CR rate of about 10%, as I showed you from Checkmate 214, rather than sequentially. So the one question that came up when the European agency EMA was looking at the results of Checkmate 214, whether to accept it or not, they said, okay, what is the contribution of IPI? You have a regimen that produces around 40% ORR, 10% CR, a survival advantage of it over a TKI, but we really need to know what is the contribution of the anti-CTLA-4 ipilimumab. So they demanded that in order for the Europeans to accept reimbursement for this, they required to have a randomized trial comparing the combination of Nivo-Ipi versus Nivo alone. And this is the 8Y8 trial that's ongoing in Europe. And you see here the experimental arm is Nivo-Ipi, and the comparator arm is Nivo plus placebo. The primary endpoint here are PFS, and secondary endpoint are listed here. So we'll see, and my prediction is that Nivo-Ipi will beat Nivo, as I showed you from these other trials that were single arm studies. But this will be the gold standard to show once and for all that Nivo-Ipi will be superior to a PD-1 monotherapy. Now, what about combining the anti-PD-1 or anti-PD-L1 antibodies with a VEGF pathway blockade? So here are a slide summarizing the phase 3 trials combining anti-VEGF with IO in first line. And again, I will not be discussing the results of bevacizumab plus atezo because they were not positive. The study was not positive, and this regimen was not approved. Genentech withdrew their application from the FDA and EMA. So we'll be focusing on these two regimens here, avelumab plus axitinib and pembrolizumab plus axitinib, these approved agents combining anti-VEGF, in this case, the axitinib plus a PD-1 or a PD-L1 antibody. Now, starting with the pembro-axi combination versus sunitinib, this is the Keynote 426, and here is the schema of the design of the treatment. Again, similar to the Checkmate 214, patients were naive, had clear cell RCC metastatic disease. Here is stratification, again, similar to the other one by IMDC risk as well as region. And here, the difference here, the endpoints, the two primary co-primary endpoints were OS and PFS in the ITT population, all patients. There was no stratification by PD-L1, and then they were just looking at it across the board, all patients. So here are 861 patients who were randomized to either pembro plus axi, and those in schedule shown here, or sunitinib, the standard dose and schedule of 4 weeks, 2 weeks of 50 milligram daily. And here are the Kaplan-Meier curves for the pembrolizumab versus sunitinib. In green are patients treated with pembrolizumab. In dark brown are patients treated with sunitinib. This is now the Kaplan-Meier curves for progression-free survival PFS, and you see that the pembrolizumab curve is on top with median PFS for, again, intent to treat, all population treated with pembrolizumab, 15.1 months median versus 11.1 months. That was a significant difference with hazard ratio of 0.69, and you can see the 95% confidence intervals under 1, and that was a significant difference with a p-value of 0.0001. And at 12 months landmark, the 12-month probability of being progression-free was around 60% with pembrolizumab versus 46.2% with sunitinib. And then here at 18 months, progression-free survival probability 41.1% versus 32.9%. Now, what about now the OS? And here is these are the Kaplan-Meier curves for OS. Again, on top is the arm with pembrolizumab, and the bottom is sunitinib. Again, a small number of percentage of events of deaths, 13.7% with pembrolizumab versus 22.6% with sunitinib. Again, landmark analysis here at 12 months and 18 months, you see that approximately 90% of the patients treated with pembrolizumab were alive at 12 months versus 78% with sunitinib. At 18 months, 82.3% and 72.1%. Again, here the primary analysis was presented at ASCO GU last year, published in the New England last year, and the hazard ratio for the difference in OS between the two arms was 0.53. This is a very low hazard ratio, and the p-value here is significant, as you can see here. Now, what about the responses? About 60% or 59.3% of patients had ORR, CR and PR with pembrolizumab versus 35.7% with sunitinib. And here we're looking at the CR 5.8% with pembrolizumab versus 1.9% with sunitinib, the PR rate here, and this is the duration of response. Now, this data was updated with a median follow-up of about 23 months at ASCO GU, at ASCO just 2 months ago, and here are the results presented by Betsy Plimak at the virtual meeting just 2 months ago. And here now you see that for OS, again, at 12 months, 90 and 79%, as I showed you earlier. At 24 months now, the OS probability is 74% with the pembrolizumab versus 66%. The hazard ratio, if you recall, was 0.53. Now the hazard ratio has increased. It's 0.68 for difference between pembrolizumab and sunitinib. Nonetheless, this was a significant difference between the two arms. Now, looking at the responses, the CR rate has increased now from 5.8 to 8.8%, and the CR rate has increased with sunitinib from 1.9% to 3%. But overall, the ORR was still around the same, 60% with pembrolizumab versus 39.8, about 40% with sunitinib. Now, looking at results of favorable risk disease, just to draw your attention that when the initial data was presented with a median follow-up of 12 months, in favorable risk, also pembrolizumab beat sunitinib for PFS, ORR, and OS for favorable risk disease, unlike the Checkmate 214, where there was no difference, or the difference was inconclusive between nivo-ipi and sunitinib. But here, with a later follow-up at the updated results, now there is inconclusive evidence to show superiority in OS with pembrolizumab versus sunitinib. And here, at 24 months minimum follow-up, the 85% of patients treated with pembrolizumab are alive versus 88% with sunitinib. Again, we're talking about favorable risk disease. For PFS, 45% versus 35% probability of progression-free at 24 months. And again, for these two, OS, time to event OS, time to event PFS, inconclusive evidence that one is superior to the other, pembrolizumab not being superior to sunitinib for that favorable risk category. And again, here you can see the hazard ratio, although it's 0.79, but the upper bound, the 95% confidence interval is above 1. And here you see a wide confidence interval for us for the with the hazard ratio being 1.06 and a very wide confidence interval. What about ORR for favorable risk? The response rate now is 70% overall with pembrolizumab versus 50% with 50.4% with sunitinib, and the CR rate here now is 11% versus 6% with sunitinib. Now shifting gears to the other phase 3 trial, combining a VEGF TKI. Again, here it's axitinib, Dr. Wood's favorite TKI, with this PD-L1 antibody from Pfizer and EMD Serono, avelumab. Again, similar treatment design, the similar treatment schema, treatment naive patients with clear cell RCC, measurable disease. And here, instead of using IMDC for risks for stratification, instead of using IMDC risk category, intermediate, poor versus favorable, they used ECOG, performance status 0 versus 1. Again, geography, as you saw in the other two phase 3 trials. Randomization was 1-to-1. This is the regimen that was the experimental arm and the dosage the schedule used versus sunitinib, again, standard 50 milligram daily, 4 weeks on, 2 weeks off. Co-primary endpoints were PFS ONS in PD-L1 positive patients. I think it's important to note here that they used PD-L1 positive, unlike the other two trials where they were agnostic to the PD-L1 status. And here are now the Kaplan-Meier curves for PFS for the primary endpoint, which is the PD-L1 population. And again, in black are patients treated with a combination with the median PFS of 13.8 months with avelumab plus axi versus sunitinib, 7.2 months, hazard ratio 0.61. This is a significant difference between the two arms vis-a-vis PFS in PD-L1. Again, looking now at the overall population intent to treat, this includes patients whose tumors were PD-L1 positive and PD-L1 negative. Again, significant difference between the two arms vis-a-vis PFS, median PFS, again, identical, 13.8 versus 8.4. Now, what about the responses? And here, you know, the PD-L1 positive and the overall population, the response rate was 55% in PD-L1 positive, with a combination 51% in the overall population. Sunitinib, again, PD-L1 positive and overall population was very similar, 25.5 and 25.7. The CR rate here was lower, as you could see here. Again, we do not want to compare across trials, but you could see that in this trial, compared to Nivo-Ipi, where the CR rate was at least 10% and slightly higher, here the CR rate is in the single digits, is lower. But overall, again, the ORR is in the ballpark where you get with pembrolizumab, although the ORR with pembrolizumab was slightly higher than this. Patients with ongoing response are here. And then here are the waterfall plots with tumor regression from baseline, the combination here and blue with avelumab and then sunitinib, obviously a broader, deeper tumor regression with the combination. Now, the results were updated for Javelin Renal 101 with avelumab and the results were published in the Annals of Oncology just a few months ago. And here are the updated results for PFS and OS. For PFS, again, for overall, for the PD-L1 positive population, again, similar to what we saw earlier, 13.8 median versus 7, a difference of a hazard ratio stratified 0.62. For OS, no difference. This has no conclusive evidence of superiority here with the 95% confidence intervals for the stratified HR crossing 1 with a wide range here. So for OS, the regimen of avelumab axitinib versus sunitinib did not show OS superiority for the PD-L1 population, looking at all risk categories. And here is again now for the overall population. I showed you the PD-L1 positive. This is for the overall population. Again, similar results for PFS, difference between the two that's significant for PFS, but for OS, again, not estimable for the OS. And again, the hazard ratio crosses 1 and this is still inconclusive for OS, whether you look at PD-L1 positive or overall population. Now, what about looking at PFS and OS and response rate? When you look at the subgroup analysis, favorable, intermediate, and poor risk. And here are the results. Just a busy slide here, but the keynote here is to mention that for poor risk patients, it appears that avelumab-axi showed a superior ORR and OS. If you look here at OS for poor risk, median OS was 21 months with the combination versus 11 months, doubling of the median OS. And this had a hazard ratio of 0.57, and the confidence intervals were under 1. So at least for that subgroup analysis of poor risk patients, avelumab plus axi was superior to sunitinib. But again, this comes with the caveat and the pitfalls of looking at subgroup analysis to draw conclusions. I think really remains to say that avelumab-axi, because it did not meet the OS for the overall population, including the primary population of PD-L1 positive, it has not caught really traction in the field, and very few people are prescribing avelumab-axi in the US. I'm not sure about India, but in the US and in Europe, very little use of avelumab plus axi in first line. Most people are using pembro-axi or nivolumab-ipi. Now, what about ongoing emerging phase 3 trials that haven't read yet, but will be read out in the near future? These are 3 studies. One is 307, a clear study looking at a 3-arm study of pembrolizumab plus lenvatinib versus lenvatinib plus everolimus versus sunitinib. This is the number of patients estimated to be accrued. We will not have the results of this trial. It has complete accrual, but it will be till next year before we have the results. Checkmate Minor, there was a press release by the sponsor, Bristol Myers Squibb, showing that the results did meet the endpoint of PFS and OS in a 650-patient phase 3 trial, comparing nivolumab plus cabozantinib versus sunitinib. The results will be presented at ESMO in a couple months, and we will see the exact data, but it will be probably similar to what pembro-axi shown. Cosmic 313 is looking at the triplet of nivo-ipi plus cabozantinib versus nivo-ipi placebo. This is an ongoing trial, and results will be a while before we have results from this phase 3 trial. So the checkmate minor here, just this is the treatment schema. As I mentioned, primary endpoint PFS, and these are the secondary endpoint. It started as a 3-arm study with the triplet versus doublet versus sunitinib, but they removed the triplet and they continued with just the doublet of nivo-cabo versus sunitinib. And this is the clear study I just mentioned, the 3-arm study. Again, the results will be, it was powered to have PFS and OS answered. No crossover because of you're looking at OS for an endpoint as well. This is the Cosmic 313 with the triplet of nivo-ipi cabo versus nivo-ipi placebo. PFS is the primary endpoint. This is a study that's really being conducted by the Alliance, and it's an ambitious study looking at the role of in intermediate risk poor risk of adding cabo, and then time, if a patient achieves CR, is 1 year of therapy adequate? So it is an ambitious study with more than 1,000 patients. We'll see if it will finish accrual. I have my doubt, but the primary endpoint is OS. Basically, patients with intermediate or poor risk RCC who have clear cell histology are randomized to everybody gets nivo-ipi 4 cycles. Those who achieve CR after 4 cycles, and that's at 10% of the patients at most, will continue with just nivo for 1 year. Those who have progressive disease will get cabo after the nivo-ipi, and those who don't have neither CR nor progressive disease, basically those patients who have basically PR or stable disease, then they get randomized to either the standard of care after nivo-ipi induction with nivo alone or adding cabo to nivo. Now, this is an important study, that single-arm study of pembrolizumab plus lenvatinib post-IO progressors. And here is the dose and schedule of this regimen. This is for patients who received, let's say, nivo-ipi upfront, had progressive disease, or received pembro-axi, or avelumab-axi, or atezolizumab, any IO-based regimen in the first line, and they progressed. they are treated with this regimen. And the primary endpoint was ORR at week 24. And the results were impressive in that at 24 weeks, the ORR was 51% with this regimen in patients who had progressed. And the median PFS was 11 months. That's impressive. The question here, are these results impressive because of additive effect from pembro to lenvatinib post-IO progression, or are the results all driven by lenvatinib? Only a randomized trial will answer the question, after progression with IO, is there a role for continuing with an IO agent or just a TKI? And I think this question will be answered by this trial. It's atezo PD-L1 antibody plus cabozantinib versus cabozantinib alone in patients who had progression on IO. So obviously, I think here, if atezo plus cabo doesn't show superior results to cabo alone post-IO progression, I think the question will be answered that really continuing with another PD-1 antibody, even if it's different from the first IO-based regimen, doesn't make sense. And of course, obviously, you reduce toxicity by not giving IO after already receiving IO in first line, and then of course, reducing cost. So what are the principal IO endpoints? In my opinion, I think I showed you that landmark analysis for PFS and OS is more important than just looking at a median. CR rate is very important and not just ORR. And why is that? Because I believe that to achieve cure, to break the barrier of cure, you really need to have complete response. And that's a golden principle of oncology that we've learned from the curable cancers of leukemias, lymphomas, Hodgkin's, germ cell tumors, etc. You need to achieve a CR, and that CR has to be durable. And I think the import when you compare or have the option of selecting an IO-TKI versus IO-IO, which one would you go with? I think it's important to really know that patients want to get out of the tunnel at the end. They want to stop therapy and have that opportunity of being progression-free, hopefully in CR, hopefully cured without any further therapy. And in my opinion, this will be achieved only with an IO or combination like nivo-ipi. And so that's the concept of treatment-free survival. Patients want to be free of treatment and progression-free as well, hopefully in CR to achieve the cure. And of course, quality of life is important with minimizing the toxicity as we move forward. I think in the interest of time, I mentioned already about the look to the future. I mentioned already some of these things about how I look at selecting therapy. I think there are challenges that remain: identification of biomarkers of response and resistance, and management of toxicity, which is not trivial. I think, as I mentioned, there is room for developing triplet regimens, adding on the backbone of nivo-ipi, or a pembro-axi plus a third agent, a novel agent. And I think I already addressed the goals of treatment for patients and for investigators in the field. I think I would like to end this with a case, if you allow me. I appreciate it, Mr. Chairman. I think, I believe one of the panels asked the question, is there a role for nivo-ipi or IO-TKI pre-nephrectomy? And here is a patient that we treated, a 43-year-old woman who presented with symptomatic disease, cough, weight loss, fatigue, dyspnea, chills, and night sweats. Her prognostic score was 70%. She had anemia, neutrophilia. These are risk factors, as Dr. Joshi showed. And she had a CAT scan which showed a left renal mass measuring 8 centimeters with liver metastasis, lung metastasis. We did a biopsy of her left renal mass, showed a clear cell RCC form in grade 3. This is a question for fellows we ask, but we can go through that exercise. Which treatment option would you recommend upfront? Cytoreductive left radical nephrectomy followed by enrollment on a clinical trial, sunitinib or pazopanib, high-dose IL-2, or induction therapy with nivolumab plus ipilimumab, followed by maintenance nivolumab. I think, obviously, we know that for patients with liver metastasis who have poor risk disease, anemia, from the data from Carmina and our own data at MD Anderson, we do not believe upfront cytoreductive nephrectomy is wise in patients like this lady. I showed you that sunitinib pazopanib for poor risk is inferior to nivo-ipi or pembro-axi, and high-dose IL-2, again, doesn't have a role here in this patient with poor risk, compromised performance status, and primary in place. So the answer here is D, and that's what we did. We gave her 4 cycles of nivo-ipi at the standard dose and schedule. The patient responded well with the resolution of all her symptoms that she had at baseline, and I'll show you the scans after the 4 cycles. So you could see here that this is her baseline scan with liver metastasis and lung metastasis, and here is again the baseline. All top 3 pictures here are from baseline. You see the large mass in the left kidney, but after 4 cycles of nivo-ipi, resolution of liver metastasis, resolution of lung metastasis, mass in the left kidney remains the same size, but you could see it's become more necrotic. And so we sent her to have, I sent her to one of my colleagues, Dr. Jose Karam, who did a laparoscopic left radical nephrectomy on her resected part of her left colon and mesentery, and did RPLND, and the pathology was clear, sulfurmin cleared 4 with extensive therapy effect, sarcomatode and rhabdoid dedifferentiation, invasive into the renal sinus, etc. But the patient responded well, and subsequently post-operatively, after she recovered, we continued maintenance therapy with nivolumab. I saw her just in June, and she is now past a year and a half from initial diagnosis. She remains NED, no evidence of disease, no metastasis in the lungs or liver or anywhere else. She has tolerated therapy extremely well with no complications. I would like to thank you for the invitation, and thank you for indulging with me for going maybe overboard in time. I wanted to share with you this case as well as the latest literature on the landscape of therapy for RCC in first line. Thank you very much for your attention. Happy to answer any questions.
Thank you, Dr. Nizar Tanir. This was a super presentation about the superpower of immunotherapy, cytokines to the contemporary era where we have reached today in immunotherapy. It is wonderfully explained, and with the illustration at the end. Because of the paucity of the time, we will straight go to the next presentation by Dr. Vineet Talwar, because we know that now we are combining this immunotherapy with the TKI inhibitors, and what are the combination and where they stand today in the real world data. The real world data about sunitinib and in the combinations and the future projections. Dr. Vineet Talwar, the eminent medical oncologist from Rajiv Gandhi Cancer Hospital, he will be presenting the place of TKIs in the present contemporary arena. Dr. Vineet.
Thank you, Dr. Sood, for the kind words. May I request Dr. Tanir to not to share his screen so that I can share mine. We are still seeing his screen here.
Dr. Tarif, can you please?
All right, sorry about that. I stopped sharing.
Yeah, thank you. So this was the topic which was given to me. TKIs in metastatic RCC, still not forgotten. So with the advent of immuno-oncology drugs, which form a very formidable challenge to the super drug of yesteryears, I'll just go through the gamut and try to argue my point that yes, TKIs are very much there, definitely in the metastatic RCC situation still now. So the basic question is, do all risk groups fare the same? This was the Adonis trial which was published in March 2020. This was the real world experience with sunitinib treatment in patients with metastatic RCC and the clinical outcome according to the risk stratification. And this showed that the PFS and OFS for first-line sunitinib treated patients, the median OS was about 34 months with the 95% confidence intervals. And the basic conclusion, I didn't go into the detail because the time given to me was about 7 minutes. So the basic conclusion was the survival estimates for patients with metastatic RCC treated with sunitinib in this real-world study. The patients who had intermediate risk with only one risk factor, the overall survival was very similar to patients with favorable risk factors. So this was a very, very important point in this trial. And we find that this was replicated in another trial. This was published in SOGO 2020. This was the STARTOR registry, in which this was a German multi-center real-world prospective registry, which included sunitinib, axitinib with metastatic RCC. And this showed that real-world outcomes according to IMDC and MSKCC in sunitinib-treated patients were almost similar when you had only one risk factor versus no risk factor, meaning thereby intermediate group with only one risk factor, the median overall survival was 37 months versus 30 months. And so was in the MSKCC criteria, it was 37 months versus 30 months. So the conclusion was that the intermediate risk group appears to be heterogeneous, and the overall survival for patients with one risk factor may align with favorable risk group, and patients with two risk factors may align with the poor risk group. So in the intermediate risk group setting, you have a dichotomy in which where you have only one risk factor, the survival, as you can see as per this, is about 30 months. Vis-a-vis, if you have the two risk factors, the survival plummets to about 18 months. So if you go by both the risk stratification criteria, whether it is the IMDC or the MSKCC, you find that the survival is more or less near the good risk group. So why I am hammering this good risk group and the intermediate risk group is because specifically the TKIs, they are the drug of choice in the good risk groups. And if you have a patient who's in the intermediate risk group and only with one risk factor, definitely he or she should not be clubbed into intermediate or high risk and should be given IOs. So these people can be given benefit of the doubt and they still can be treated with the TKIs to give them the required benefit. Now, another question which comes into the mind is TKI after TKI in a responding patient, does the duration of response matters? That means if a patient is on a TKI and does very well, say 1.5 to 2 years, and after that progresses, does that patient respond from another TKI vis-a-vis a patient who's been on a TKI and progresses, say, after 6 months or 9 months? So this was the axis group sub-analysis. This was a poster presentation in SOGO, optimizing axitinib treatment selection following first-line sunitinib treatment in metastatic RCC. And in this, this was pitted against sorafenib, which was 195 patients. And you found that in this, the percentage of patients in favorable and intermediate group were almost the same if you saw by the MSKCC criteria or the IMDC risk group criteria. The patients with mets in the bone and liver were almost the same, and bone and or liver were 89. And the duration of prior therapy, which was less than 10 months, was about 98 patients, and more than 10 months again was about 94% patients. And these were the results in which you find that axitinib post-sunitinib shows better effect in favorable intermediate risk group tumors who have low tumor burden, that is less than 10 centimeters, and it fares well in patients who have no bone or liver mets. So here you can see favorable or intermediate risk group patients versus the poor risk group patients. You find that there is a stark difference in the overall survival. Meaning thereby, if a patient has done well with the prior sunitinib and the duration has been more than 10 months. And even at this point of time, patient has a low tumor burden and preferably no liver or bone mets. These are the patients which can be challenged again with a TKI, and these patients do well. And these were the PFS results with the axitinib versus sorafenib. And this showed that the IMDC favorable or intermediate risk group, which were non-bulky disease, there was no bone or no liver mets. These ones, they favored axitinib over sorafenib. This was just a differential between both the two TKIs. Suffice to say that if this is the subgroup, then these are the patients, they can be again put on TKI and not switched over to any other type of drugs. So the conclusion was that axitinib remains a suitable second-line treatment option in patients with non-bulky disease, patients who have favorable or intermediate risk, or patients who had no bone or liver metastasis, which, as all of us know, they tend to fare worse. The third question which comes into our mind whenever we are debating against TKI versus other drugs is, does the site of metastasis affect the outcome in these patients? So this was the cabozantinib trial in which cabozantinib was pitted against the current standard, which was sunitinib, and it was 1:1 randomization, and it was in patients who had no prior systemic therapy, and it included the IMDC intermediate and poor risk groups. And the primary endpoint in this was the progression-free survival, and the secondary endpoint was the overall survival, and of course the safety of the toxicity profile. And some more points were included in this, that is the PFS for patients with high proton oncogene, that is the MET expression by IHC, as compared to patients with low MET expression. And there was an IMDC risk stratification with IMDC risk group and bone mets. So one thing to highlight is that, of course, cabozantinib was definitely better than sunitinib. If you saw the subgroup analysis or the progression-free survival in these patients as per IRC, it was found that patients who were having this MET status positive, they definitely did better than patients who had sunitinib. And also the patients who had bone metastasis, they did much better than patients who had sunitinib. Suffice to say that if you have a subgroup of patients who have intermediate or poor risk group, and they are the ones which you have bone mets only, and probably they might have or may not have MET amplification, these are the ones again which can be put into TKIs. And another thing which has been happening now is that why patients who are good risk patients, why they tend to do good with the TKI and why not with the immuno-oncology drugs, that is Ipi/Nivo. This was the paper which was published in the European Association of Urology. It showed the response of primary renal cell carcinoma to the systemic therapy. And this was a study design which was a conglomeration of phase 2 and phase 3 studies. And the patients were identified as having one target lesion within the kidney in the absence of nephrectomy. The objective of this study was to study the effect of upfront systemic therapy on primary tumor. And in this, it was found out that patients who were given first-line therapy as any therapy in these tumors, the response rates were about 19%. The patients who were subjected to VEGF targeting therapy, that is first-line, in this the response rates were 28%. And the median time to the best objective response rate was 7.5 months. So this study characterized that the effect of systemic therapy on the primary tumor, upfront VEGF targeted therapy leads to an ORR of primary tumor of 28%. And again, it showed that patients have a higher VEGF expression when they are in good risk. And that is the reason when you give only immuno-oncology drugs, they fare worse. Vis-a-vis, if you give a combination of immuno-oncology plus TKIs, or if you give only TKI drugs, they tend to fare better, which was seen in sunitinib versus Ipi/Nivo trial, and which was again seen when you combined an IO drug, that is pembrolizumab, with axitinib. Prior nephrectomy or not, well, this is again a very contentious issue. I will not delve into more because it's going to raise a lot of firestorms. The points to consider here are that the rates of nephrectomy, prior nephrectomy in all these frontline trials which have been discussed prior, that is whether it is the Checkmate trial, where you have Neo-AP, or the Keynote trial where you have the Pembro-Exe, or the Javelin trial where you have Avelumab and Axitinib. In this, the rates of prior nephrectomy were about more than, it was going north of 80%. So the direct impact of immuno-oncology combination on the response rate of the primary tumor in these patients without prior nephrectomy has not been characterized fully. Now here we are saying that the primary tumor in these patients without prior nephrectomy was not characterized. So how can we give the IO the benefit of the doubt? And additionally, the rate of prior nephrectomy in patients with complete response is not specified in these studies. So these can be argued from this point of view. Now, again, coming to response evaluation. Now, response evaluation is, can you afford the potential scenario of a pseudo-progression always? How much can you rely on pseudo-progression? Why? Because some metastatic sites can be drivers for decision for pro-TKI also. So, pseudo-progression, giving patient the benefit of the doubt, which might turn into a frank progression, you might, lose the bus. So that again is a point of contention when you use TKIs versus IOs. Toxicity as a driver for treatment decisions. Well, if you see the clinical experience, I think I would request one of the
Dr. Pramit, can you please mute? Yeah, thank you.
Yeah, thanks. So if you see toxicity as a driver for treatment decision, that is TKIs versus IO, clinical experience with TKI is vast. Prophylactic measures available, yes. Therapeutic measures, definitely yes. Incidence and severity and dose dependence, definitely there is a tandem correlation. Rapidly reversible after treatment discontinuation, yes. Whereas when you see IOs, clinical experience, it's a bourgeois branch, meaning thereby that is we are learning more and more as the time is passing. Prophylactic measures, apart from steroids, they're very scanty. Incidence and severity of dose dependence, it is no, you don't know where it will, patients will have side effects versus patients who will not have side effects. Rapid reversibility after treatment discontinuation, answer again is no. B cell is in the killing mode in these patients. And if you have seen amongst the pivotal trials, especially the ipilimumab and the nivolumab trial, the Checkmate trial, more than 60% of patients were subjected to salvage with corticosteroids. So that again is a food for thought. Now coming to the histologies, non-clear cell histologies, well, if you see the sarcomatoid types, yes, definitely the immuno-oncology drugs have shown to have some benefit. But then if you see the others, that is the papillary, the chromophobe, the rhabdoid types, the other types, does the IO drug fare better than TKI? The answer at this point of time, especially I'll say at this point of time, is no. When you see the ASPEN, the ESPEN, and the RECORD-3 trials. So, will they apply across all subtypes, the IO drugs? The answer again is, a big no. So there, comes the rationale of combination. That is where we combine the VEGF with the PD-L1 or the PD-L1. As I said, the combination of PD-1 with VEGF was a success when it came to pembrolizumab plus axitinib, that is the Keynote study. And why it was? Because the very fact that the onco driver in the low risk groups is again the VEGF and not the others. So when you combine both of them, elevated VEGF may inhibit first the dendritic cell maturation and cause immunosuppression. And VEGF inhibition may reduce the number of Tregs tumor and again the invading myeloid derived suppressor cells. And anti-VEGF therapy may prime, again, after the inhibition of the dendritic cell maturation and the Tregs, it may prime for a better effect of anti-PD-1 and PD-L1 therapy. So these were my thoughts, for TKIs, and definitely when you see in these niche areas, TKIs definitely have a big role to play even now in the immuno-oncology era. Although, you can debate it either ways. So I think I'll stop here and I thank you very much.
Thank you, Dr. Vineet. Thank you.
With this, we have come to the end of the second session. We have 2 more sessions. We are running behind schedule. Without wasting the time, for the next session, I would welcome my esteemed chairpersons, Dr. Yuvaraja, Dr. Gilil Kumar, Dr. Anup Gupta, who doesn't require any introduction, or stalwarts in the field of uro-oncology in India. And I also request Dr. Robin Joshi, uro-oncologist from Nepal, to chair this session. Over to you, Dr. Yuvaraja. Just one small announcement. We have more than 350 members glued with this webinar, and more than 60 from Bangladesh and more than 15 from Nepal. So over to Dr. Yuvaraja and other chairpersons too.
Thank you, Raghu. Can you hear me, Raghu?
Yeah. Yes, Yuvraj. Yes.
Welcome. And I think we are running later, short of time. So I would invite all the speakers. So in the beginning, I think I would like to congratulate Dr. Sudhir for spearheading this launch of this society. I think in future we'll have a lot of uro-onco meetings. So I hope that we'll learn a lot. And the first speaker will be Dr. Christopher Hood. We will be speaking on role of cytoreductive nephrectomy, which is really a burning issue for urologists. So I welcome Dr. Wood to give this talk.
Thank you, Mr. Chairperson. So I've been assigned to talk about cytoreductive nephrectomy and if there's still a role for this in the management of patients with metastatic renal cell carcinoma. Prior to 2006, when all we had to treat patients was the immunotherapies, interferon and interleukin-2, nephrectomy did play a major role in the treatment of patients with metastatic disease. The question is, in the era of IO and TKI therapy, is there still a role for cytoreductive nephrectomy? The group from UCLA were one of the first to recognize that nephrectomy in combination with immunotherapy resulted in a better outcome for patients than either modality alone. And this resulted in the conduct of 2 randomized phase 3 trials, one done in the United States and one done here, one done in Europe, where patients were randomized to upfront cytoreductive surgery followed by interferon versus interferon alone. And both the EORTC study shown here, as well as the SWOG study shown here, demonstrated a benefit for cytoreductive surgery prior to the administration of immunotherapy with interferon. And the group from UCLA sent a letter to the editor following the publication of the SWOG study, where they used the SWOG criteria for entry in their own database where patients received high-dose IL-2, which they posited was a better therapy than interferon, and noted that patients who had high-dose IL-2 had a significantly better outcome than the patients that had interferon in combination with cytoreductive surgery. And so now we have all these better therapies, and the question is there still a role for cytoreductive surgery in the setting of all of these different better therapies than interferon and high-dose IL-2? Well, we may believe that cytoreductive surgery in combination with these therapies does result in a better outcome, but we are not practicing what we preach. You can see from this study done in 2011 that right at the time of introduction of sorafenib and sunitinib in 2005, cytoreductive surgery went on the decline. So why would we not argue for cytoreductive surgery? Well, the morbidity and mortality can be significant. It's only been proven beneficial in combination with interferon, which is an inferior therapy. It's possible the patient may spend the rest of their time on this earth recovering from that surgery, and there could be significant disease progression or morbidity associated with surgery that may preclude them from getting systemic therapy after surgery. And perhaps these new therapies may result in primary tumor regression. The potential benefits of cytoreductive surgery: it can alleviate or prevent local symptoms. It can eliminate the main or at least one source of further metastatic progression. It could alleviate systemic symptoms such as paraneoplastic syndromes and tumor cytokines and growth factors. And with one surgery, you could remove more than 75% of a patient's tumor burden. How does it work? Well, to be honest, we really don't know. Is it a reduction in major portion of tumor burden? Is it some sort of immunologic phenomenon? Is it somehow altering the metabolic milieu with a relative renal insufficiency causes a metabolic acidosis, which is somehow anti-tumoral? Or perhaps it results in the removal of secreted factors from an endocrine or paracrine phenomenon that promotes progression and metastases. We really don't know. This was an interesting study that we performed where we looked at the role of cytoreductive surgery in the setting of non-clear cell histology. And you can see that patients who had cytoreductive surgery had a better outcome than those patients treated with their primary tumor in place. However, it was not the same result as we get with clear cell histology shown on the black line. So this suggests to me that just pure tumor burden removal is not the role that cytoreductive surgery plays. This was a study done by the SWOG group that did the randomized phase 3 trial. And what they noted was those patients who had post-surgery azotemia, an increase in their creatinine after surgery, had a significantly better outcome than those patients that did not have a change in their creatinine after surgery. And back in the day, we used to look at patients' histology, and if we saw this infiltration of immune cells, we would hypothesize that those patients would do well because their immune system was attacking the cancer. But in fact, those patients did the worst. And now we know, thanks to the work of Jim Allison and others, that in fact the tumor was turning off their immune system, and that's why those patients did so poorly. And now we have drugs that can target this interaction. Is there any clinical evidence for the systemic influence of the primary tumor? Well, we've all heard about paraneoplastic syndromes. There's the rare phenomenon of spontaneous regression following cytoreductive surgery, and also the explosive progression of metastatic disease following cytoreductive surgery, which thankfully is rare. Tony Schwery published this retrospective study looking at the role of cytoreductive nephrectomy in the era of sunitinib and targeted therapy. And although this is retrospective and admittedly biased, it does demonstrate a significant benefit for patients who had cytoreductive surgery prior to the administration of sunitinib, with a doubling of survival. That's not to say that cytoreductive surgery is for everyone. Patient selection is clearly critical, and the first to recognize this were the group from Tufts, who noted that those patients who could have greater than 75% debulking, the absence of brain, liver, and bone metastases, and good performance status with clear cell histology had a significantly better outcome than patients that lacked these criteria. We were one of the first to delve into the selection process for patients with cytoreductive surgery. This was a paper that was published by Steve Culp and our group back in 2010, where we compared patients who were treated with their primary tumor in place to patients who underwent cytoreductive surgery, and we identified the following risk factors as predictors of outcome. Those patients who had a low serum albumin, a elevated LDH, the presence of liver mets, the presence of symptoms related to metastases, nodal involvement, be it in the retroperitoneum or in the thorax, as well as locally advanced T stage. All of these factors predicted for a poorer outcome with cytoreductive surgery. And we noted that those patients who had 3 or less factors had a significantly better outcome than the patients treated with their primary tumor in place, and therefore we hypothesized that they might have benefited from cytoreductive surgery as compared to patients who had 4 or more factors. Their outcome was similar or worse to the patients treated with their primary tumor in place and likely did not benefit from cytoreductive surgery. There are other retrospective studies that are out there looking at different criteria that can be used to select patients for cytoreductive surgery. This is from Danny Hang using the IMDC criteria. And they noted again that if you had more than 3 of the risk factors, that you're less likely to benefit from cytoreductive surgery. And this is a meta-analysis looking at a variety of different retrospective studies looking at the role of cytoreductive surgery. And you can see that all of them basically demonstrate some benefit from cytoreductive surgery. Admittedly biased, admittedly retrospective, but it is data that suggests that removing the primary tumor is beneficial in patients with metastatic disease. This was a study looking at the role of cytoreductive nephrectomy from the NCDB database. There were 15,000 patients. Almost 7,000 of them had cytoreductive surgery, and you can see that for all patients with metastatic disease and subsets including clear cell and non-clear cell histology, all of them had a benefit from cytoreductive surgery as opposed to the initial treatment with targeted therapy. This was a study, this was a subset of that study that tried to look at whether or not giving targeted therapy first and then doing cytoreductive surgery was better than doing upfront cytoreductive surgery alone. And you can see that basically at both 3 and 6 months, initial targeted therapy followed by cytoreductive surgery was really no different an outcome relative to patients that had upfront cytoreductive surgery. Obviously, the elephant in the room is the Carmina study, which looked at the role of treating patients with sunitinib alone versus nephrectomy followed by sunitinib. And this is the study schema. I just wanted to delve a little bit into the factors for the patients that had nephrectomy and no nephrectomy to look at how these patients were selected. And if you go back to those criteria that I mentioned from the CULP study, Many of these factors that are in this paper where patients were randomized to surgery or no surgery are found here. You can see that a significant number of patients had locally advanced T stage, particularly in the nephrectomy arm. There was a lot of nodal disease in the study, and patients with bone mets, lymph node mets, liver mets, treated brain mets were included in this study, none of which we would use to select these patients for surgery. They also stratified patients by the MSKCC risk criteria into intermediate and poor risk, and I'll touch on this a little bit more in just a minute. And so you can see from the results of the study that sunitinib alone is not inferior to nephrectomy followed by sunitinib in patients with metastatic clear cell carcinoma. And the medical oncologist at ASCO tweeted from the rooftops, there's no more need to do cytoreductive nephrectomy on patients with metastatic renal cell carcinoma. Well, I would argue not so fast. First, we need to remember that this trial did not reach its accrual goal. It took 8 years to accrue, and that comes out to 0.7 patients per center per year. And I would argue that if you're going to a center that does less than 1 cytoreductive nephrectomy per year, you probably should not go to that center. 16 patients in the surgery arm did not have surgery, and 38 patients in the no surgery arm actually had surgery. They allowed treated brain mets, liver mets, bone mets, extensive nodal mets, all were allowed in the trial. And I would argue that these are patients that we would not likely operate on in current clinical practice. 40 patients in the nephrectomy arm never got sunitinib, arguing that they were significantly poor risk and couldn't recover from surgery to get their treatment. And only 11 in the sunitinib arm never got sunitinib. Again, the trial was stratified by MSKCC criteria, and I would argue that these criteria are used to assess prognosis and response to therapy. They were never meant to select patients for surgery. And there's the MSKCC criteria, which have been talked about earlier in this presentation. Nonetheless, the European Association of Urology came out with these recommendations, which basically say that there is no role for cytoreductive surgery. Well, we went back to the drawing board and took a look in more modern era of targeted therapy and tried to identify factors that might predict for outcome in cytoreductive surgery. You can see that we did this retrospective analysis, which was literally published a month ago in Cancer. And these are the factors that we identified as independent predictors of a poor OS in patients undergoing cytoreductive surgery. Systemic symptoms at diagnosis, adenopathy again, both retroperitoneal and in the thorax, bone mets, hemoglobin less than the lower limit of normal, albumin less than the lower limit of normal, elevated LDH and locally advanced T stage, as well as an elevated neutrophil to lymphocyte ratio. So comparing our study from 2010 to our current study in 2020, you can see that liver mets fell out of the mix, but that's probably because we don't operate on patients with liver mets. And symptoms at presentation due to metastases fell out, although I would argue that systemic symptoms at diagnosis is probably the same thing. And stage 3 fell out as well. What fell into the mix in terms of being predictive were systemic symptoms at diagnosis, hemoglobin less than the lower limit of normal, bone mets, and the neutrophil to lymphocyte ratio of greater than 4, although we didn't really look at that in 2010. And we would argue that patients who have 3 or less of these factors had a significantly better outcome with cytoreductive nephrectomy than those patients who had more than 3. And so we would divide patients into low, intermediate, and high-risk groups. If they had less than 2 factors, we would consider them low risk, and you can see their median survival was 58.9 months. Intermediate risk, their survival was 31.2 months. And those patients who had more than 3 factors, their median survival was 19.3 months. And I want you to remember that number for just a minute. So if you look at the results of the Carmina trial, basically the median survival for the group that had cytoreductive surgery and the group that had sunitinib was right around that 19.3 month level. The Carmina trial showed that patients who had sunitinib alone, their median survival was 18.4 months, and patients who had cytoreductive surgery followed by sunitinib, their median survival was 13 months. And I would argue that those median survivals are unheard of in the targeted therapy era, which clearly demonstrates that the population of patients enrolled in that trial were poor risk and were not destined to live a long time. Similarly, in the CERTIME, which looked at the deferred versus immediate cytoreductive nephrectomy, again, the median survival of the immediate cytoreductive nephrectomy group was 15 months, which is extremely lower than in our study. So let me conclude by saying that cytoreductive surgery still has a role in the era of targeted therapy. Targeted therapy has dramatically improved the outcome for patients with metastatic disease, and I believe immune checkpoint blockade should improve upon that. But without complete responses in all patients, surgery still has to remain an integral part of a multidisciplinary approach in metastatic disease for control of the primary tumor, as well as metastasectomy. Patient selection remains a critical component of success with cytoreductive surgery. I didn't have a chance to talk about the pre-surgical approach, although we touched on this earlier. It's not really clear when it's most appropriate to integrate surgery into the context of metastatic disease. I'd like to thank all of the people from the organization that invited me to speak. I apologize, unfortunately, I have surgery starting in half an hour and I'm home, so I'm gonna have to head to the hospital. I have a couple of minutes to answer a few questions if there are any, and then I'm gonna have to move on. But thank you very much for inviting me, and thank you very much for listening to my presentation.
Thank you, Dr. Chris Wood. It was an excellent topic, excellent presentation. Just about the topic, we would like to have a quick comment from Dr. Nazir Tanir, because we surgeons generally feel that cytoreductive nephrectomy hasn't got the death sentence because of the Carcinoma trial. What is your opinion about, as a medical oncologist, and where you put the cytoreductive nephrectomy in the present day of management? Dr. Nazir Tanir?
Nizar, are you on the call?
Dr. Nazir Tanir? I think
he's already gone.
Okay.
Looks like he dropped off.
Yeah.
Yeah, any of the medical oncology.
We can ask either Vineet or Amit.
Vineet, Amit, or Shekhar Patil.
Shekhar Patil.
Hello.
Yeah.
Yes.
Yeah. What is the exact question?
Yeah. At present management, where do cytoreductive nephrectomy stand in the perspective of a medical oncologist? Because we feel that Carcinoma trial hasn't given a death sentence, as Dr. Chris Wood has rightly discussed. So do you feel that cytoreductive nephrectomy has to be completely stopped, or is still there is a role for cytoreductive nephrectomy?
Hello.
Yeah.
Can you hear me? Actually, still in the current era, definitely cytoreductive nephrectomy has not lost its place. So in a good risk patient, definitely we want to consider upfront. So in a poor risk patient, definitely we want to defer. In intermediate risk, then the question in the individualized decision has to be taken whether to go for cytoreductive nephrectomy upfront or just to wait, start the TKI, just see how the patient is doing. What in my practice, what we are doing, that we start the TKI. If the patient responds to the therapy, there is a good reduction in metastatic site. Then after 6 months or 8 months, then we take a call regarding doing nephrectomy in that patient. The only important question which is still remaining in the that was in the TKI era. In the immunotherapy era, the again question comes: what should be in the so that is still an unanswered question in immunotherapy. For TKI, things are relatively clear, but in immunotherapy, still we are evolving and we are learning whether to. I think the foreign faculty can definitely put some point of view regarding this.
Dr. Chris Wood, what do you feel about the role of cytoreductive nephrectomy in the new era of immunotherapy?
Well, I mean, as I said in my talk, I challenge the idea that stratifying patients into good, intermediate, and poor risk based on MSKCC criteria has nothing to do with selecting patients for surgery. I think that, you know, our study from 2010 and now from 2020 demonstrates the factors that you should be looking for in a given patient population to better select patients for surgery. And those should be the criteria that decide whether or not upfront cytoreductive surgery should be performed. I can tell you that we are doing cytoreductive surgery upfront less and less, and more treating patients upfront with systemic therapy and then taking them for delayed cytoreductive nephrectomy, but that's not without its problems as well. I can tell you I just did a cytoreductive surgery on a patient that was treated with IO therapy, and it was tough. I mean, there's a lot of inflammation, a lot of desmoplastic reaction, and it can be very challenging to control the hilum doing that surgery. So it's not something to be taken lightly or something that should be considered a routine part of clinical practice. But that said, I would say that more and more we are doing delayed cytoreductive surgery as opposed to upfront cytoreductive surgery.
Yeah, Ginil, I can ask the last question to the Professor Wood.
Yeah.
Yeah, Professor Wood, my question is that you told the surgical. So what do we call this criteria as? MSKC's criteria is for the TKIs and the systemic treatment, and this criteria is called a surgical criteria. What do you call them?
The criteria that I presented?
Yeah. So
you call it the Wood criteria.
So we have to refer. Is this called as MD Anderson criteria?
Yeah, this is based on a study we did at MD Anderson.
Surgical criteria.
Mm-hmm.
Can I ask you one question, Chris? What do you think the role of IO in organ confined, like a small renal masses? You give IO and do the surgery, or maybe you can avoid doing the surgery with a complete response in future. Is it going to happen?
The short answer is I don't know. As you know, there's a clinical trial through ECOG where patients are randomized to surgery or randomized to neoadjuvant therapy with IO therapy followed by IO therapy after surgery. That will give us some indication of the activity in the locally advanced setting for these agents, but I don't know that we'll ever be able to, without a clinical trial, ever be able to use IO in like small renal masses or locally advanced disease without doing a clinical trial to examine its impact.
Thank you, Dr. Kiswood.
Chris has to go, so we will miss you, but let us...
Thanks for the invitation, Sudhir, and stay in touch, please, okay?
Yeah, sure. Thanks for joining us. I know this is a working day for you. We are in the night, so we will be delaying our dinner. We'll go on. Thanks a lot, Chris.
Take care.
Take care. Bye-bye. Over to Yuvraj, Ginil, and others.
Ginil, you can invite other speakers. Anup or Ginil.
Anup, now next speaker is Dr. Raghavan. The talk is about metastatectomy in the RCC. We know that metastatectomy is coming up in a lot of analyses, the role of metastatectomy in RCC. Over to Raghavan.
Thank you so much. I hope all of you can hear me and see the screen. I'll be super short, ultra short, because I am not going to stop any of you having dinner. So metastatectomy for RCC. So we'll just ask a very simple question: when, for who, and how? We know that a lot of change has happened in the RCC from the days when we were trainees to where it is today. We have super duper treatments, and that the field is very expanding as well. But we still have substantial patients who either have primary metastasis or delayed presentation after the primary treatment is done. The most common sites of mets are lung, bone, lymph nodes, liver, adrenal gland, and brain. Now, so metastatectomy came from the concept that we are able to remove the metastasis and hence give them an extra longevity. We all agree that we probably may not give them cure, but at least we give them longevity. The important decision maker points are performance status, the disease-free length before the presentation of metastasis, whether synchronous or metachronous, the burden of the disease, number of locations, and the sites involved. So these are the points at which I'm going to discuss. All of them have one slide and I'm just going to move it forward. So if we take the prognostic factors, this is a wonderful paper from Von Poppel's group. T-stage, Ferment grade more than 3, DFI more than 12 months, or less than 12 months, non-pulmonary mets, and multiple sites. More the risk factor, worse the prognosis. So just for the trainee's sake, T-stage more than 3, grade more than 3, DFI less than 12, non-pulmonary met, and multiple sites. In the molecular subtypes of clear cell RCC, it's only applicable only for clear cell. The clear cell RCC type 1 and 4 are at risk of early relapse, and therefore their prognosis is bad. 2 and 3 have favorable outcomes. Incomplete versus complete. It makes sense to understand that if you give an R0 resection, even for a METS, you get a better survival. Just the curves speak for itself. The OS and CSS is much better compared to incomplete resection. Solitary versus multiple. It makes sense that solitary metastasis resection have a much better prognosis compared to multiple sites. What is very important to know is that it doesn't matter which the landing site is, adrenal, lung, pancreas, thyroid, or liver. What is very important is the disease-free interval after nephrectomy. Longer the disease-free interval, irrespective of the site, they still have a good prognosis. And according to the organ sites, the best sites is lung. Lung metastatectomy has the best outcome as far as the overall survival is concerned. These are the bones and brain do very badly. If you have a bone and you want to do a resection of the bone, think twice whether it is going to be worthwhile for that patient, because you can treat them with other means like radiotherapy and so on and so forth. But if you have a solitary bone mets and you are sure that this is going to help the patient, then a resection attempt is worth it. Embolization of the bone mets can be done to reduce the intraoperative blood loss and to reduce the symptoms in terms of pain. Now, you can also treat the bones with radiation as well, and radiation giving a single dose will be very good. Now, RPLND, if you have node metastasis presenting more than 12 months after the primary nephrectomy, it's worthwhile considering this section because you do get a decent amount of progression-free survival. Liver has always been the friend to the kidney. Traditionally, also liver resections have always been yielding good results for us, and that remains that way as well. I will share the PowerPoint presentation in the global group so that the trainees can use that for their reference. Especially if you are having a liver met presenting a year or two later from the primary tumor, or you have a concurrent disease which can be R0 resection can be achieved, it's absolutely worth pursuing that. Even Professor Chris Wood showed a case where he did a non-segmental hepatectomy for the patient. Interestingly, pancreas metastatectomy also has good prognosis. There are a lot of reports published for that. Brain mets is the worst of all the mets, brain and bone. If you have a solitary met, a stereotactic radiotherapy is much better. Whole brain radiation for diffuse metastasis is recommended. Surgical candidate, you have to think many times before it is worth doing it, and therefore I'm saying that it's not that recommended as a resection point. Integration of systemic therapy, there are pros and cons for it. Upfront systemic therapy versus upfront surgery, and we can discuss till the cows come home. We don't have an absolute answer for that, but the wind is blowing towards the neoadjuvant therapy, as we can see from the previous talks. So this slide, I think, is the most important slide. The good features for metastatectomy and bad features. ECOG, fantastic ECOG, clear cell pathology, group 1 and 2, DFI more than 12, solitary mets, organ signs such as lung, pancreas, liver, compared to the brain, bone, and lymph nodes. So the current guideline is that the metastatectomy is recommended as a weak recommendation because the number of studies to support this is very small, especially randomized studies. And the first line of therapy is still a TKI, or if it's a clear cell, you can do a SBRT, which I think Vedang is going to talk about that as well. Take home message: most of the studies are primary and retrospective. Synchronous metastases have worse prognosis, but it is worth the resection if you can give an R0 resection. Metastatic sites such as brain and bone have the worst prognosis. It is for a small subgroup of patients, but it is worth a consider for an option for them. The best candidates are good performance status, a long DFI, relatively low burden of disease, achievable R0 resections, and dedicated multidisciplinary cancer teams. Thank you so much.
Thank you, Dr. Raghavan. It was excellent presentation as always. So we'll go to the next presentation. It's a very, very interesting talk, emerging role of radiotherapy in RCC. And we have one of the top radiation oncologists from the country, from Tata Memorial, Dr. Vedang. So we're looking forward to his talk. Over to Dr. Vedang.
Yeah. Hello, good evening, everybody. Good. Fine. Fine. Okay. So last, I think, but probably also the least in this case, I would say, because radiotherapy has a rather limited role in RCCs. And I'll not be talking about the primary treatment of primary tumors, but only of locally advanced and metastatic disease. My talk is about the evolving role, but to just complete the picture, let me spend a couple of slides on the rather old role or known role. In the early 70s and 80s, radiotherapy was tried pre-operatively. It did not work, so there was no benefit, so it is not considered anymore. We tried much harder to study post-operative radiotherapy. There was better local control with post-op RT, but no improvement in DFS or any other outcome, significant outcome. So that is now not considered as a standard of care either in the randomized trial. These trials had a lot of toxicity because they were large fields treated without any significant shielding. Another established role is that of stereotactic radiosurgery, which evolved from the 1960s and 70s for intracranial metastasis. And as Raghavan rightly pointed out, these patients' outcomes are rather dismal as compared to other sites. Interestingly, as the use of SRS increased in a certain institute or in a certain country, it was associated with improved OAS, overall survival in RCCs. Generally, the local control at 1 year is 90% in multiple studies. I'll show you data later. SRS or radiosurgery for intracranial tumors maximally helps in patients who have smaller lesions and fewer lesions. And generally, it is considered safe to combine it with TKIs. But there is a word of caution here with immune checkpoint inhibitors that I will talk about later. So that brings us to the emerging role. And I'll be talking about three things: SBRT for local recurrence, SBRT for extracranial metastasis, particularly spine and lungs, and again SBRT with immune checkpoint inhibitors. So what is this SBRT that I'm talking about in my last slide? This is a seminal paper from the 70s. A very famous radiobiologist named Gordon Steele and his group, they came up with they looked at several cell lines and looked at 2 Gray fractions, which is a standard fractionation. And they came up and said that renal cell cancer with melanoma, sarcomas are radio-resistant tumors. But a lot of things have changed since then. You know, we now treat with much higher dose per fraction called hypofractionation. We give, instead of 2, we give 8, 10, 12, 15, even 20 Gray in one fraction. So that is possible because of technology. And what that does is, it, rather than the standard way of cell kill, it activates what is called as, among other things, sphingomyelin ceramide pathway that does a number of things differently. And again, I'll talk about it a little later. So that is what SBRT does, and that is the role, and that is why there is so much more excitement now, and there is an evolving role. Coming to local recurrence, in this excellent overview of management of local recurrence by the EAU, young oncologists, young urologists actually, if you carefully look at this, and thank you Raghu for sharing this paper, there is those patients who have failed after surgery, who have a local recurrence and are not candidate for surgery. Radiotherapy has kind of sneaked in there, although you must notice there that's with a typographical error, but believe me, it does work. And this basically is for a local recurrence. The philosophy is based on the evidence from the treatment of primary, for which there is rapidly increasing amount of data. And if it can treat the primarily effectively, in certain cases, it would be effective for local recurrence only. The data for this is rather weak, but it is practiced reasonably more around the world, also in India. And I think most of the radiation oncology community in India would be able to deliver this safely. Most of these are combined with systemic therapy. So this has to be remembered as an option when surgery or RFA or thermal ablation are not options. Coming to probably the most studied aspect of SBRT in RCC is treatment of metastasis. These are extracranial metastasis. And in this review, wonderful overview, it talks about local control rates with very low toxicities to the tune of nearly 90%. Most commonly, Raghavan mentioned spine and brain are the worst sites. This is probably one of the reasons probably is they don't undergo surgery as well. So, but if you look at, and the older series have used standard radiotherapy of 20 grain, 5 fractions, 13, 10, that really doesn't work in RCC. What SBRT does as compared to standard radiotherapy is it improves pain relief and it improves local control. It is important to select these patients properly for SBRT spine. I'm not going to the technical details. For example, the patient should not have mechanical instability of the spine. Those are better served with surgery. But there are a number of options available for treatment, single fraction to up to 5 fractions, and these are the things that are chosen based on the site. And the volume of disease. Pulmonary metastasis lends itself very well to radiotherapy if required. If there is a case of metastatectomy or for some other clinical indication, there is a large experience of SBRT of the lung primary, so we are able to do this very well now. This is an overview of meta-analysis of a lot of studies that have looked at the outcomes. As I said, on the right side, you can see 90% local control at 1 year when brain is treated. And on the left, you can see nearly 90% local control, over 90%. This is all the studies with SBRT at 1 year. So it is really truly an ablative treatment for even for a radio-resistant tumor like RCC, and should be considered when surgery is either not possible or may not be considered. We ourselves have treated about 20 patients over the last few years of SBRT in metastatic RCC, various sites. We've not had a single grade 2 or higher toxicity, and only one patient has had a local recurrence. The most exciting thing probably is combination of SBRT with immune checkpoint inhibitors. This is the truly evolving bit of this talk, and because it is evolving, I will not be going into too many details. It is used in 2 strategies. One is to use SBRT as a way of either deferring or systemic therapy or improving PFS or outcomes when it is oligometastatic upfront, or as a way in oligoprogressive disease when the patient is already on systemic therapy of eliminating resistant clones. So 2 broad strategies. A number of studies are going on, large and small, including a few with dual blockade of IPI and NIVO. So I think this study was recently presented at GU ASCO. I'm not going into the details. But there are more questions than answers. What is the right dose of radiation? It is known that the single fraction has to be over 10 gray to activate the ceramide pathway that I was talking about. The combination is not very clear, and the sequencing is also being studied in a number of studies. But one has to be careful. As I said initially, there is some reports that combining immunotherapy with SBRT, stereotactic radiation of the intracranial mets can lead to increase in radiation necrosis. That really depends on the volume and the timing. So one has to be careful about doing these things and jumping onto the bandwagon. I'll finally leave you with a concept of what is called as abscopal effect. For those who don't know, this is a very kind of what we only read about, we hardly see in practice, but you can see the number of papers that have gone up since 2012, which coincides with the availability of immunotherapy. It's basically effect of radiation at a place that is distant from where you have actually irradiated. So this is what is seen and thought to be immune mediated. And there is more and more talk and discussions in the literature that instead of treating one site, we should be able to treat multiple sites now. And this would make the tumors more visible to the immune checkpoint inhibitors and probably enhance the immunogenicity. So I'm just leaving you with that thought. Thank you so much.
Thank you, Dr. Vedang. I think we had this conventional teaching that RCC is a radio-resistant tumor, and these more concepts are evolving. I just have a small question for you. In your experience, if the response of this RT to RCC varies as per the histology, or it's same for all histologies?
personally, I do not have experience of various histologies to be able to differentiate, but I think most of the data is with clear cell, and I'll not be able to give you that answer very clearly. I think most of it is with clear cell histology.
Okay. So I think over to my co-conveners, because I think we have short of time. So,
yeah, I think we can proceed. Dr. Joshi from Nepali, UK, you have any comments?
Oh, I don't see him.
I think he is not there.
Yeah.
Okay. Thank you so much for all the speakers. I think it was a wonderful session. So I think we'll keep the questions later because now we are starting in our time.
Yeah, sure.
Over to Dr. Raval. Sir.
Yeah, Yuvraj, thank you. And since we have less time and our Chris has gone, because he was saying that he has got multiple cases. He was very interested in asking a lot of questions to us. So I have one case, but before that, I think we will have the question and comments from the other faculty who wanted to come to make comments, ask question. But then for that, I'll invite Ganesh, Dr. Ganesh Bakshi, Dr. Gagan Gautam, and Dr. Sanjay. Dr. Saroj is from Nepal, probably he may not be there. And Dr. Ganesh has left because he was saying probably, is Dr. Ganesh there? No. Dr. Nizar is only left. Dr. Jagdish Kulkarni is there, and Dr. Srinivas Chilkuri.
Yes, sir. No, I'm back here, Sudhir.
Okay, Ajay,
Sudhir,
sir
I'm
is
back.
back.
I'm still waiting for
you,
up and down with the the connectivity here because a lot of wind.
Sure, sir. That's great. Great to have you. So, I'll ask first Dr. Anant Kumar. He wanted to ask or make some comment on first talk from Chris Wood, which was on management of locally advanced RCC and role of neoadjuvant therapy. Before I go for my cases, Dr. Anant, you are busy with the phone. You are talking to a patient. Hello, you are mute. Can you unmute? No. Dr. Anant, are you going to ask or shall I ask somebody else?
Yeah, okay. See, I was on phone. Okay, tell me what.
Yeah.
Question?
Yeah, you were asking a question which I said that because of the paucity of time, I stopped you on the first talk of Chris Wood.
Yeah, he has replied to that in chat group. Actually, I was asking him what is the interim result of the neoadjuvant immunotherapy in RCC, neoadjuvant setup.
Okay.
So he said trial is going on. He doesn't know the results. He has replied.
Is Vineet? Okay. Is Vineet there? Vineet or Joshi? Amit Joshi is there. We need one medical oncologist.
Yes, sir. Can question?
Okay. Amit. Yeah, Amit is there.
Yes, sir.
So,
yes, sir.
If anybody has question, he can ask. Otherwise, I'll go with my case.
Sudhir, can I ask one or two questions to the medical oncologist?
Sure, sir. Sure.
So one thing is about this papillary. If you get this papillary histology, and let me be more precise. If it is say type 1 hereditary papillary renal cell or HPRC, so then which drug? Because a lot of things are now coming up in this area, and because there is a separate pathway, they are talking about even germline MET mutation. Whether that should, do you go up to that extent?
Yes, sir. Yes, sir. Basically, I think few days back there was a data regarding the use of bevacizumab plus erlotinib in the HL-RCC. So they did the trial of all papillary RCC patient in the same regime, the bevacizumab, that is anti-VEGF therapy, with the erlotinib, that is it's a tyrosine kinase inhibitor. And what they found that the patient who harbors who have this HL-RCC, they have a significant response. Was around 20 months. So in a patient of a HL-RCC, definitely there is no doubt that we should consider this combination of Bev plus Arlo with that data. Regarding the MET mutation, sir, I think there are trials are already going on. I think in next year or at the end of the next year, we will have a drug which is targeting the MET mutation. So definitely the things are changing. For a patient of a papillary RCC, not otherwise specified, we still prefer using the sunitinib over the everolimus because of the ASPEN trial data. So in a non-selected patient, sunitinib. In patient with HL-RCC, we prefer using Bev plus Arlo.
So very nice. So just one more question about this potential use of the biomarkers. When you are using the TKIs like sunitinib, pazopanib, we are all using, and there were a lot of papers talking about the CA9 amplification and HIF estimation, alpha 1, and so is it all in some practice? Because I read it long ago.
No, it's still all were of has been proven that it works in predicting the response or not response. So it's still the time-tested data of the risk stratification. So no biomarker we are considering in this scenario.
Thank you very much.
Thank you, Amit. I think I'll ask question during the discussion of this patient. It is a 60-year-old male presented with pain in the left lumbar region, hematuria, weakness, and loss of appetite. He had left renal mass with mild ascites. You can see that there is a hepatic outflow, occlusion, abdominal pain, ascites, hepatomegaly, lymphedema, and abnormal LFTs. There is the mass. He presented with these features. What is the diagnosis? Liver side. Dr. Kulkarni, some of you might have seen this case before. Dr. Jagdish Kulkarni.
Sorry. I'm sorry. Can you show me once more? Can you go back once more?
Okay, sir. This is the thing. And I'll just tell you that left lumbar region, hematuria, weakness, loss of appetite, left renal mass with mild ascites also.
Okay.
He has some.
What is happening in liver?
Liver is a vascular lesion, you can say.
Oh, so is this a liver met?
No, this is something else. So that is why I bought this. This is an interesting case. Anybody else? Anybody can make a comment on this? Maybe Gagan, if you would have seen this case before.
Sir, I got a butt Chiari? Has he got a butt Chiari?
Yes, sir. This is butt Chiari.
Butt Chiari, isn't it?
Yes, sir. Yeah, this is butt Chiari.
Yeah.
So there's the diagnosis that left renal mass with butt Chiari syndrome. Now, my question is to anybody everybody can say what will be the approach? Nephrectomy, angioembolization, neoadjuvant target therapy, angioembolization followed by target therapy or immunotherapy, or you will just do FNAC biopsy and leave the patient. Gagan or Sanjay, I think. Sanjay is there? Gagan?
Okay.
Yeah.
If the patient otherwise is fit enough, I would like to consider doing the nephrectomy.
Straight away.
Because you haven't said that he has got metastasis anywhere else.
No, there is no mets, but there is the liver which is bad, which has got LFT
He has
deranged.
got ascites as well. Okay.
LFT deranged, he has got ascites. Gagan, any change in the plan?
Sir, I would like to take the gastroenterology consultation for this. And let them give a little insight about what are his surgical risks before deciding on going for a surgery.
Okay. They say there is no risk. Then will you offer surgery or?
Then I will give you a call and ask you for what
to do. Dr. Ganesh, sir.
This butt Chiari could be as a result of outflow obstruction to the hepatic veins.
Yes, sir.
And want to know whether actually there is no tumor thrombus anywhere?
No, sir. No.
You've not shown us.
No, but there is no thrombus.
One of the things that people actually do is to put a transjugular catheter and take the venous pressure off, and then you could go ahead and do the nephrectomy, because this has got probably nothing to do with the tumor. And if you say he's got no metastasis, the ascites is probably as a consequence of the butt Chiari with the deranged LFT. His outcome is generally going to be poor, but if there's a window that all his LFT is deranged because of the hepatopathy that as a consequence of RCC, it might just revert after the nephrectomy.
Okay. Any role of target therapy or immunotherapy, Vineet or Amit? Vineet? Is
Not
Vineet
at this
there?
point of time.
Hello.
If this is a localized disease.
Rawal? Yeah.
Hello.
Yeah, Vineet, go ahead.
Yeah. If it is a localized disease and the gastroenterologist gives a clean chit, then I would suggest that we go ahead with nephrectomy than giving any.
No, if suppose the gastroenterologist doesn't give a clean chit, then what will be your preference? Will you give target or immunotherapy nowadays in this time?
Well, if you think of a neoadjuvant therapy, a classical neoadjuvant therapy, there is, at this point of time, if you go by the guideline, no role of neoadjuvant therapy in a disease which is limited to the kidneys. If you talk of a quasi-neoadjuvant therapy in which you have metastatic disease and you want to cytoreduce, then probably you can give IO or TKIs and you can discuss it either ways, the pros and cons.
Dr. Anant, you wanted to make? He's busy with the phone.
Okay. Rawal, does the patient have a portal hypertension addition or no?
Yes. This is Budd-Chiari syndrome, sir.
What are they thinking? They need to do something for the portal hypertension?
I actually took the opinion. They said it's not fit. It's better that if you do something before surgery. So what we did is we have a very good interventional radiologist. We have a cath lab. We did first FNAC, needle biopsy. It showed clear cell carcinoma. And then angioembolization was done. And after that, he was put on sunitinib 50 milligram OD for 2 weeks by 1 week. Patient improved and blood supply of the liver also improved and ascites disappeared. So that's what actually we have. I have seen such cases in many time in panel discussions. So we had some knowledge of this thing. So this is how we managed. I was asking about IO and IO. Right now, we do not have any experience except probably Amit and Vineet can enlighten, though we have seen the data from MD Anderson that they give extrinsic. We were very, sunitinib is very handy. Even at this time of, IO is not, ipilimumab is not there in country. So maybe in future, the things may change. So you can see that after angioembolization, the liver improved, the tumor came down, and we did nephrectomy. Anybody for continued target therapy here? If you see the good response.
What is the
it's
clear cell.
Clear cell.
Nothing beyond the kidney. Organ
nothing beyond the kidney.
I think I would stop it.
Yeah, absolutely. Nothing more.
Okay. Makarand, you want to say something?
Yeah. Just wanted to know, how do you explain the response to embolization and sunitinib? Was this Budd-Chiari was something a paraneoplastic manifestation, you think?
Yes.
Yeah, that's what I felt.
Yes.
Yeah.
Fine. And what about the liver enzymes? All the enzymes also revert back to normal?
Yes. Everything improved.
Everything.
He was fit for surgery.
Okay.
So will you do surgery or continue target?
I think I would be tempted to do surgery because he responded very well. Do surgery and then continue with TKIs again. He has responded to sunitinib. So you can.
Gagan, what will you do?
So if he has no measurable disease after nephrectomy, then I don't think there is any current role of an adjuvant TKI in this setting, sir.
No. We are talking before that. He had angioembolization. We gave target therapy.
No, I would agree that we should go ahead and do the
surgery.
Yeah,
I agree. So he had radical nephrectomy. Sorry, there was IVC thrumbus.
I asked you, hey.
I'm sorry. Sorry, sir.
Dr. Sudhir, I asked you whether there's a thrombus, and you said there was no thrombus.
I'm sorry. There was thrombus.
The Budd-Chiari is developed because of IVC thrombus.
Yes.
Yeah, of course.
Yes.
Yeah. So Sudhir, I was thinking whether you are talking about Stoffers all this time or Budd-Chiari. I was totally,
no, that was my fault. Actually,
down. And I agreed actually with Dr. Ganesh.
He asked
when he started with thrombus, actually, I was also about to say that this has to be because of thrombus.
Sir, I think this was a googly, deliberately bold by you.
Chinaman.
Okay, then histopathology is clear cell carcinoma, live thrombus and lymph nodes were negative. What will you do? Now, Vineet or Amit can answer. We should continue target therapy or we stop it?
I will stop it.
Yeah.
Okay.
If the biopsy says no evidence of residual disease.
Yeah, that's great. So
Can I
think
raise a question, sir? Now that, though you didn't tell us that it was an IVC thrombus that was causing blockage to the hepatic veins, causing all the problems, wouldn't that mean that if you knew it, you would go ahead and do a radical nephrectomy rather than the way you went around?
No, the thing is that there was a ischemic lesion in the liver and he had ascites and rearranged LFT. So we thought of doing first portal vein embolization and then go ahead with this thing. I think there's taking a chance if you do straight away nephrectomy in such cases, you may come out or you may end up in problem. This way it is safer. Sir.
If you just go surgery without taking care of what you did, this patient would have died because when there is ascites and there is a liver congestion, the mortality is very high.
Yes, sir.
If that part is taken care of, one should not operate.
Sir. So with that, I think we will conclude this webinar. This was first webinar and we had around more than 350 attendees, which I got the information from Fairing. I would like to thank Fairing to organize webinar and to agreeing that all the webinar of SOGO will be done by them. They will take care of all the webinar in future.
Very good.
And I will ask now Dr. N.P. Gupta to say a few words. After that, Dr. Jagdish Kulkarni to conclude the webinar.
Sudhir, I apologize that I could not join you earlier. We decided to visit to Dr. Rakesh Tandon. You know, he expired yesterday. He was professor and head of gastroenterology at All India Institute of Medical Science, and he was a dear friend of ours. And he has shifted to Gurgaon. He was like our neighbor. So we have also made a group here actually. So we are meeting quite often. Till yesterday morning, he was very regular in his morning walk and all that. He went for a walk. While he was returning home after 2 kilometers of the walk, he collapsed and he was immediately shifted to Paras Hospital where he was brought dead actually. You know. I'm sorry I could not join you. And that visit was there. Now at the outset, I like to congratulate you for creation of this society, which was the need of the day. And as you know, in all our practice now, our uro-oncology cases are increasing day by day because of the increase in the longevity of the life, as well as by the better diagnostic modalities for early diagnosis. And as far as therapy is concerned, now there are so many advances are going on. So I'm sure that this society will serve the purpose. And I wish you all the best for this new endeavor. Thank you, Sudhir.
Thank you, sir. Dr. Jagdish Kulkarni, conclusion.
Good evening to all the seniors.
I just switched off the video.
Dr. Rawal, Dr. Raghunath, and all the colleagues. This is a historical moment for me. Sorry?
I didn't know who you were referring to as seniors when you are the senior most amongst all
the senior. Dr. Gupta, Dr. Ganesh. No, we have Dr. Gupta, Dr. Ganesh, Dr. Mahesh Desai, and this is an as I say, historical moment for us. 1986, when I was fellow with Dr. Donahue in US, told, and that was time when Dr. Whitmore, who is the father of uro-oncology, had retired, and it was dedicated to him. So I would like to dedicate this kind of meeting to our first uro-oncologist of India, Dr. M.R. Kamath, who started uro-oncology division in 1974, which is almost 46. We wish him the health. Much. As far as the uro-oncology development is concerned, was for uro-oncologist. In 80 to 90, myself and Dr. Srinivas became. Then doubling time occurred in 90s. There were 4 uro-oncologists, which is Dr. Tongavkar, Dr. Kochikar, Dr. Rawal, of course, and Dr. Kashyapi, and thereafter to the turn of the century, the doubling time has reduced. However, from a less than 2-digit uro-oncologist, now we are now going to a half a century of the uro-oncology, which is a great thing happening to the uro-oncology. Now, what is the future? The future is, then uro-oncology was a solo urological domain, but now there are other specialties which are also putting the thing into the field that they would like to be the part of the uro-oncology, that this should be a multidisciplinary, right? And I agree with this. This has to be multidisciplinary. Now, what is the difference? It is also one challenge which we are likely to face is because of the number of uro-oncologists are growing by the day. Now, where do we make this? This is 100% uro-oncologist dedicated to content. But let's take it from a broader perspective that this is a growing field, and these things are going to be there for us. And I'm extremely happy to be the first president of the Uro-Oncology Society. And let us celebrate this, a new era in uro-oncology, surgical, as well as medical oncology and other specialties. And with these remarks, I would like to thank you all and thank you, Fairing, for S.K. Raghunath, that this is the concept which I considered in 1986 when I came back. I asked Dr. Kamath, he said, first you will have to develop uro-oncologist. Maybe he said it may not be in my lifetime, but I'm fortunate that in my lifetime it is developed. Thank you very much. And all the best to you.
Thank you, sir. Thanks to Dr. Ganesh, Dr. Gupta, Gagan, especially joining this place because I thought Gagan may be more towards surgery. He may not like discussing medical oncology and radiation. But you have to learn these things. I love practicing some of the medical oncology. So to learn more and more, we will be coming back. Sir, can you announce the next webinar, Dr. Jagdish?
Next webinar is 25th August, 3 weeks from now. Is that correct? 25th.
Yes,
so see you then.
Okay, sir. Now finish.
And good night.
Bye-bye. Good night.
Thank you, sir. Thank you very much.
Good night, everybody.
Thank you, sir.
Yura Janub, thank you.